So I have taken this topic, these topic. This is the third lecture in the series of 5 lecture to completely finish the obs and gynae for your NEET PG as well as FMG. All those people who are on Google Meet, please give a thumbs up if I am visible and if I am audible. Okay, okay, thank you. Total there are 7 people. So just be with me. So now first we'll understand diagnosis of hypertensive disorder. So for diagnosis, please understand, make a timeline like this. For example, this is day 0 of the pregnancy, and this is the 37 week, which is a full term delivery, and delivery has taken place. And this is 12 weeks post delivery. This is 12-week post delivery. This is 12-week post delivery, and here this is the 20th week. Second thing, when you will say that a patient has a high BP, if the BP is more than or equal to 140/90. So in a pregnant lady, we will say that her BP is more if it is more than 140/90. So if we diagnose, if a lady BP was normal during this time, here BP was normal, and after 20 to 30 week BP increased. So BP was normal from 0 to 20th week, and after 20th week BP increased, which remains increased till 37 week and even after 12th week, and it becomes again normal after 12th week post delivery. So such lady will be called as a will call to have gestational hypertension. This will be called as gestational hypertension. Very important. That means she has a high BP after 20th week. Before 20th week, the BP was normal, and after 12th week, after 12 week of the delivery, BP again become normal. This is called gestational hypertension. Now, same lady that is having gestational hypertension also has significant proteinuria. Then this lady will be called as preeclampsia, double E. Then it will be called as preeclampsia. This is what is significant proteinuria? I'll tell you. Now, if this lady of preeclampsia also gets convulsions, and most common type of convulsion is generalized tonic-clonic seizure, then this will be called as, complete thing will be called as eclampsia. That will be called as eclampsia. So gestational hypertension, that is BP was normal before 20th week and it increased after 20th week, and it remains increased till 12th week post delivery, and then it becomes normal. If there is significant proteinuria along with gestational hypertension, that is called preeclampsia, and if preeclampsia is accompanied with the convulsion, that is called as eclampsia. Now I'll tell you what is significant proteinuria. Now if a lady has a high BP during this time, that is before 20th week, or a lady has hypertension even after 12th week of post delivery, then that is called as a chronic hypertension. That will be called as chronic hypertension. Okay, because then we say that this lady has the cause of hypertension is not the pregnancy. So when is chronic hypertension? Two categories: either the BP is increased before the 20th week of the pregnancy, or BP remains elevated after 12th week post delivery. These two conditions will also be called as chronic hypertension. If any of this is present, then they will not be included in gestational hypertension. Now, what is significant proteinuria? If any of the four is present, then it will be called as significant proteinuria. What is For example, if there is more than 300 mg of protein in 24-hour urine sample, more than 300 mg of protein in 24-hour of the urine sample, then it will be called as significant proteinuria. Or in a spot sample, in spot sample, it is more than 30 mg per dl, 30 mg per dl. Or if you do the urine dipstick test, it is more than or equal to +1 urine, +1. Earlier it was +2. Please remember, now it is +1. Okay, so this is the change that Williams has mentioned. Okay, so if any of the is present more than 3, and the fourth, very important, urine protein upon urine creatine ratio more than 0.3. If I ask you which of them is best, the first one is best, that is 24-hour urine sample. So if in a 24-hour urine sample there is more than 300 mg of protein, or spot sample more than 30 mg per dl, or urine dipstick +1, earlier it was +2, or urine, that is, this is known as UPCR. It is written in short UPCR, that is urine protein to creatine ratio of more than 0.3 suggest a significant proteinuria. So this was the diagnosis of hypertension disorder in pregnancy. And these are the things that we will: preeclampsia, eclampsia, diabetes, shoulder dystocia, thyroid, and cardiac disease, that we will finish today. Now, normal vascular remodeling. This is very important. Now, please understand this with very, please understand this clearly. Now, if this is the uterus, okay, and this part is decidua basilis, this is chorionic plate, okay, and this is your umbilical cord, and this is a baby, okay. Now, so this is the fetus, your fetus, this is umbilical cord, and this is chorionic plate, and this is your decidual plate, decidual plate. From C, remember, toward the child, that is toward the child we have chorionic plate, and opposite that is decidual plate. Now, in this chorionic plate we have these structures, convoluted structures. What are they called as? They are called as chorionic villi. They are called as chorionic villi. They are called as chorionic villi. And in the decidual part we have arteries, small arteries. These arteries are called as spiral arteries, spiral artery. After all, we will see that these are the basic areas or the loci from where the pathogenesis of preeclampsia started. Preeclampsia, spiral arteries are a branch of uterine artery. They are a branch of uterine artery. Okay. Now, and this is our convoluted structure, that is chorionic villi. And in between chorionic villi, there are spaces. These spaces are known as intervillous spaces. Intervillous spaces. Okay. Now, in chorionic villi, we have fetal blood. We have fetal blood. Please understand this very clearly. In chorionic villi, we have fetal blood. In spiral artery and in intervillous spaces, we have maternal blood. We have maternal blood. And maternal blood contains oxygen plus the nutrients. Okay. So what happened? The oxygen and nutrients from the maternal blood comes like this, comes into the, it is just like the alveoli of the lungs. Okay. So from the uh, intervillus spaces. In the intervillus spaces, we have maternal blood containing the oxygen. Understand here also, this is intervilli space. This is chronic villi, and this is the intervillus spaces containing oxygen and nutrient, which are taken inside the chorionic villi, and from chorionic villi it goes to the fetus. So the barrier is basically it is the chorionic villi. Now, if I'll draw chorionic villi here like this, convoluted structure like this, and what is around them? This is the maternal blood. This is the maternal blood, which and the space is known as intervillus space. This space is known as intervillus space. Now, this the chorionic villi has two layers. One layer is towards the maternal blood. One layer is towards the maternal blood, and this is called as syncytiotropoblast. Syncytiotropoblast. And then there is a layer inside that is called as cytotrophoblast. Cytotrophoblast. This is a normal fetus. What happens is that, now understand this cytotrophoblast. Please keep them in mind. This cytotrophoblast, which is present inside the chorionic villi, comes out and goes into the intervillus space, and from intervillus space it goes into the decidua basalis. That means they come here, and then they go into the spiral arteries. I'm again telling, this cytotrophoblast goes into the first intervillus space, then they go into the decidua basalis, and then they go into the spiral artery, and then through a lot of very micro biological step, they causes remodeling of spiral arteries. Remodeling of spiral artery. What they do? They cause dilatation of spiral artery. So that, why dilatation? For example, if the initial spiral artery is like this, after cytotrophoblast invasion, when the cytotrophoblast comes inside the spiral artery, then its diameter becomes like this. So spiral artery, so the resistance of the spiral artery decreases, the diameter increases, and this is, they become a loose vascular channel. They become a loose vascular channel. Please understand this. So now normally, again I am telling you, uh, normally this cytotrophoblast is present where? It is present inside the layer of chorionic villi, but it moves out into the intervillus space, then it goes to the decidua basalis, and then it goes to the spiral artery. And from the spiral artery, when it moves to the spiral artery, this step is known as endovascular invasion. That is endovascular invasion. And when it comes to the decidua basalis, this is known as extravillus cytotrophoblast. It is known as extravillus cytotrophoblast. And then it causes remodeling of the spinal artery. Now, question has been asked that remodeling of spiral artery is done by first cytotrophoblast, not syncytiotropoblast. Second, it start at 12th week and it ends at 18th week. It starts at 12th week and ends at 18th week. Therefore, all the parameters of preeclampsia, eclampsia, gestational hypertension is taken after 18th week, that is 20th week. So someone can ask you now, why we take 20th week as a parameter, that before that if the BP is present it is called as a gestational hypertension, it is will called as chronic hypertension, and after 20th week it will be called as uh, gestational hypertension, because remodeling starts at 12th week and ends at 18th week. Now this is a normal thing. Okay, so three questions has been asked that I have told you. If the cytotrophoblast doesn't come to intervillous space, or if there is a decreased invasion of cytotrophoblast into the intervillous space and decrease cytotrophoblast inside the spiral arteries, okay, then what will happen? So there will be less. Now let me change the color. So these cytotrophoblast, if they will be less, then what will happen? There will be less invasion of cytotrophoblast into the spiral arteries, and the remodeling will not be proper. And when the remodeling will not be proper, so spiral arteries will not be able to relax or increase their diameter. So spiral arteries will not become a loose vascular channel. They will not become a loose vascular channel. And this, if if spiral artery is normally like this, and a normal pregnancy, it becomes like this. And when there is a remodeling is not proper, because the endovascular invasion of cytotrophoblast, that is cytotrophoblast, there is decrease in the cytotrophoblast coming to the spiral arteries, then they will remain like this, or they can even decrease their lumen, or spiral artery can even become tortuous. So what will happen? There will be oxygenation decreased oxygenation to the placenta, decreased oxidation to the placenta and to the fetus. Okay, there will be decreased oxidation to the placenta and fetus. So what will happen? There will be increased secretion of the inflammatory mediators. And first, these inflammatory mediators will cause endothelium damage to the placenta, and then they will cause endothelial damage to the whole body, which we call as a preeclampsia. So preeclampsia is a type of syndromic thing which starts from the placenta. Why? Because there is the endovascular invasion of cytotrophoblast is not proper. There is decreased or no invasion of the cytotrophoblast into the spiral arteries. So this remodeling is not proper, and they doesn't become into loose vascular channel spiral arteries, and the spiral arteries remains a high resistant channel. So there is placental ischemia, and when there is placental ischemia, there will be increased inflammatory mediators, and they will damage the endothelium, and when they will damage the endothelium, there will be a multi-systemic involvement. Thus it is like a syndrome. Okay, so now let's see this through a diagram. So what I've told you, that this part is what? This is your decidua basalis, this part. This is your spiral artery. This is your chorionic villi. This is the chorionic villi, this. And chorionic villi, I have told you the inner layer is cytotrophoblast, inner layer. And the outer layer is syncytiotrophoblast. This is the umbilical cord, this is the baby. And this area, this is known as intervillous space. And this is the spiral artery. So what happened that this is the cytotrophoblast, it goes into the extravillous space, that is it goes into the decidua basalis. Then cytotrophoblast goes into the spiral artery. This is known as endovascular invasion. I have told you. Then spiral artery becomes loose vascular channel, that is low resistance channel. So blood easily moves to the baby and there is no placental ischemia. This process is known as vascular remodeling. It starts at 12th week and ends at 18th week. So I've explained you this completely, this diagram. Okay. Now what happened? Now, but if this is a normal spiral arteries, in cases of preeclampsia, or when there is not proper, if there will be a proper remodeling, so this spiral artery will become like this. Its diameter will increase. But when there will be not proper remodeling, that is in preeclampsia, it will become like this. So in preeclampsia, it will become like this, preeclampsia. Why? Because there is no proper endovascular invasion of cytotrophoblast. So there will be placental ischemia, and there will be more um, inflammatory mediators will be formed. Now, whenever there will be more inflammatory mediators will be formed, three things will happen. Okay, this I'm going to tell you. See, so whenever if this is a placenta, this is the baby. So there is defective vascular remodeling. There is defective vascular remodeling. So what happened? There is increased inflammatory mediators. Now, so there will be endothelial damage. So if someone asks you what is the main starting point, it is the endothelial damage. And this endothelial damage will cause three basic things. It will cause leaky capillaries. Leaky capillaries. That is the fluid will come outside to the capillaries. First thing. Second, it will cause thrombus formation. Thrombus formation. And the third thing that it will cause is vasospasm and ischemia. So this is, and this endothelial damage initially happens to the placenta, then it will be in the whole, then it will be in the kidney, in the lungs, and even in the brain. So we will see what all those things that happen. So no, so decreased endovascular invasion of the cytotrophoblast in a spiral artery. So this happened. Then spiral artery becomes high resistance channel, that is pathological remodeling. I've told you. So placental ischemia and release of inflammatory mediators, damage to the endothelium, which initially limited to the placenta. Initially placenta, then involves the whole body. It will then involve the whole body. And then I've told you there will be these three things. That is, first is the vasospasm and ischemia, then leaky endothelium, and third is the thrombus formation. These things will happen. Now, what? So first we will understand all those three things we have to understand. First, we will understand what happens to the leaky. If, for example, if this is the capillary and it becomes leaky, fluid will come to the extravascular space. Now, we have first understand in terms of brain. It comes out in occipital lobe. It will cause occipital edema. It will cause occipital edema, and due to which there can be temporary vision loss. There can be temporary vision loss. Please understand. And this is known as amaurosis. 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 This is known as amaurosis. This is because of the occipital edema. This is because of the leaky thing. Now you will understand each and everything why you get. Secondly, there can be generalized edema. There can be generalized edema, and because of this generalized edema and increased glutamate, there can be convulsions. There can be convulsions. So any drug which acts, which is anti-glutamate, which inhibits glutamate, will be will act as an anticonvulsant. That therefore, when we give MgSO4, it also has an anti-glutamate. It acts on the NMDA. It acts as an NMDA antagonist, and this glutamate acts on the NMDA receptor. So it therefore MgSO4 prevents the convulsion. I will tell you in detail about MgSO4, but I'm just correlating it with. And this generalized edema along with the glutamate can cause convulsions. Okay, now, so this happen in the brain. Now, because of this generalized edema, there can also be headache and vision disturbance. Vision disturbance. Please, there can be headache and vision disturbance. This I have told you. So this happens in the brain. Similarly, if you come to the lungs, what happen in the lungs? There can be increased extravasation of the fluid, and whenever there will be increased extravasation of the fluid, it will be caused as It will lead to pulmonary edema. It will cause pulmonary edema, and that will be precipitated in the form of dyspnea. Therefore, in preeclampsia patient, whenever there is dyspnea, the first thing that we suspect is of pulmonary edema, and the cause is in front of you. Okay, so I think you understand this part. Now please remember, this edema, the this edema that is prevented, that happen, there are two types of edema. One is vasogenic edema, and other is cytotoxic edema. So I am telling you the difference between them, and that will also help you in cases of medicine. Vasogenic edema involves only white matter. It involves only white matter. Cytotoxic involves white plus gray matter. Cytotoxic edema you see in cases of especially stroke. Vasogenic you generally see in cases of tumors and abscess. So when you will see the MRI in cytotoxic edema, if this is the gray matter, for example, and this is the white matter, you can easily differentiate the gray and the white matter, because in vasogenic edema, the white matter is only white matter is involved, gray matter is not involved. Okay. I will tell you yes. So in preeclampsia, there is vasogenic edema. In stroke, I'm telling that vasogenic edema is present in tumors and in abscess. In stroke, we get cytotoxic edema. Yes, in cases of late, but these things will be, you will study in medicine, that initially in late stroke, that is after 6 hours, even the gray matter is also involved. So then you can get everything. But initially, for differentiating purpose, you have to understand that vasogenic edema is present in tumor and abscess. After 6 hours, it can also involve vasogenic edema. Understand is like this. For example, if this is the brain cell and this is the artery, if there is an infarct, so blood will reach, less blood will reach, there will be ischemia. So there will be edema inside the cell, there will be cell death. So this is called as cytotoxic edema, and slowly the endothelium will also be involved, so there will be leakage of the capillary, then there will also be a vasogenic edema. Okay. So in stroke, initially there is cytotoxic edema followed by vasogenic edema. This is very important. Okay. But for solving NEET PG, you have to understand like this, that vasogenic edema is seen in tumor, in abscess, and in cases of preeclampsia. Okay. So it involves only the white matter. I'll show you the picture. So you can easily differentiate between the MRI and in MRI, you can easily differentiate the gray and the white matter. Whereas in cytotoxic edema, which involves the white and the gray matter, you cannot differentiate between the gray and the white matter. Okay. So I think this is clear. I'll show you an image. So I've told you that the edema in preeclampsia is vasogenic edema. If it involves occipital lobe, that can cause occipital blindness, which is known as amaurosis. And there is generalized edema along with the increased glutamate can cause convulsion. This I have also already told you. And because of generalized edema, you get severe headache and blurring of vision. And in the lungs, you get pulmonary edema and dyspnea, and on finding, you get a bilateral crypts. Now, if you see this diagram, this is the stroke. Here you see, you cannot differentiate between the gray and the white matter. Okay, so this is what? This is cytotoxic edema. Because I have told you, in cytotoxic edema, you cannot differentiate between the gray and the white matter. Whereas this is the tumor. And here, this is because of the vasogenic edema. Vasogenic edema, where you can differentiate between the gray and the white matter. So this in what is this result? In ischemic cytotoxic edema, edematous gray and white matter becomes difficult to distinguish. So see, in cytotoxic edema, it has becomes difficult to differentiate between the gray and the white matter. That is what I have told you. While in vasogenic edema, which only involves the white matter, density difference between the preserved gray and edematous white matter increases. Okay, because in vasogenic edema only white matter is involved. It says na preserved gray matter. That gray matter is preserved. So this is what you will have to understand regarding this. Now, third is if there is a leaky capillary in the kidney and the lower limb. If there is a leaky capillary in the lower limb, what will happen? You will have a pulmonary edema. See, pulmonary edema in a normal pregnancy will be till ankle, will be till ankle. Any pulmonary edema above ankle, any pedal edema above plus it will be not stationary. That is, it will be more after walking. After walking, it will be more, and it will be decreased in the morning. It will be decreased in the morning. So this is a normal pedal edema. That edema, it will be more after the walking, and it will be gone in the morning. So it will not be stationary in cases of the pregnancy. But if the edema is stationary, that it is always present, irrespective of the day of the time or irrespective of the rest, and edema is present above the ankle, or if pedal edema is associated with ankle clonus. This has been once asked in PG exam, ankle clonus, then that will be called as pathological pedal edema. So when we'll call a pedal edema to be pathological, any three: ankle clonus is present, it is above the ankle, third, it is always present irrespective of the rest or the time of the day. Now, what happened in the kidney? For example, if this is the kidney, we have known that in normal pregnancy, the renal blood flow increases, GFR increases. Therefore, there is more. So when GFR increases, there is more filtration of the uric acid and creatine. Therefore, the normal level of uric acid and creatine, what we take outside the pregnancy, is decreased. For example, if we take normal creatine value till 1.1 as normal, but in pregnancy, the normal creatine value is till 0.8. So a value of creatine more than 0.8 in pregnancy will be taken as abnormal. But in a normal person who is not pregnant or a male person, a value of more than 0.81 but less than 0.1 will be taken as normal. Why? Because in pregnancy there is increased GFR, increased renal blood flow, so there is more filtration. So we decrease the upper limit of creatine, and the upper limit of creatine is 0.8. This is one thing. But what happened in preeclampsia? I have told you there is decreased renal blood flow. Renal blood flow in pregnancy, the renal blood flow normally is increased to 400 ml per minute. 400 ml per minute. In preeclampsia, there is decrease in the renal blood flow and decrease in the GFR. So serum creatinine increases, uric acid increases. They both increases, and there is decreased renal blood flow. Also, we have seen that there is, we know where the glomerular filtration occurs. There is the endothelium. This is the endothelium. This is the basement membrane, and this is negatively charged. So when it is negatively charged, and protein are also negatively charged, so it repels the protein. But this negative charge is gone because of the basement membrane damage and endothelium damage in cases of preeclampsia. So what happened? There is protein, more and more protein loss in the urine. So increase protein loss in urine. So now understand, there is a decrease serum creatine filtration because renal blood flow has increased, the decreased GFR has decreased, so serum creatine has increased in blood. But in urine, serum creatine will decrease because filtration has decreased. Okay, compare and contrast it with the normal pregnancy. Now, so when in preeclampsia, if you will take the urine sample, in urine sample, what you will see? You will see that there will be increased protein, there will be increased protein and less creatinine. Therefore, what we have calculated UPCR, that is urine protein to creatine ratio increases, and a value more than 0.3 is suggestive of preeclampsia. Hope you understand this very clearly. Why urine PCR more than 0.3 is taken? Okay, in normal pregnancy there is increased renal blood flow, increased GFR, so the upper limit of creatine is decreased to 0.8. But in preeclampsia, renal blood flow and GFR again decreases, so there is increased serum creatine in the blood, increased uric acid in the blood, but their value decreases in the urine, and there is increased protein loss in the urine. I have told you the reason. So urine protein to creatine ratio increases and it becomes 0.3, and if it is less than 0.3, no preeclampsia, that is normal pregnancy, because in normal pregnancy GFR is increased, so creatine is coming in the blood. Okay, so this is what I wanted to tell you. So decrease in renal blood flow and GFR, so increase in blood creatine and uric acid. This happen in the preeclampsia, I am telling you. Now increased capillary leakage, endotheliosis, and loss of the negative charge ions from the basement membrane lead to increased proteinuria. So in urine, ratio of protein to creatine increases, which is known as UPCR, and a value more than 0.3 is indicative of preeclampsia. I hope so. This has been asked question. What is the most common cause of kidney failure in preeclampsia? So it is acute tubular necrosis. Acute tubular necrosis. And if this is not given in the option, then you will go for the efferent arteriole constriction. Constriction. Okay, so this is what most common causes acute tubular necrosis. Now, this is a question to you. Will the same amount of blood loss in a normal pregnant lady and a lady with preeclampsia will lead to the, for example, if the lady, there are two lady A and B, both have 12 hemoglobin 12 gram per dl, 12 gram per dl, and if she loses 1000 ml blood, both of them loses 1000 ml of blood, then what will be the new hemoglobin? Will it be same or will it be different? So answer is it will be different. Why? Because I have told you in cases of preeclampsia there will be increased capillary leakage. So because of the increase, now what happen in a normal pregnancy, if this is the blood vessel is dilated because of the progesterone, peripheral vascular resistance is decreased. So and more extracellular fluid comes inside the blood. So there is increased blood volume. There is increased blood volume. This is what happens in normal pregnancy. So there is hemodilution. There is hemodilution. And why nature has provided you with this hemodilution? So that if so now if this is the RBC, there is also water along with it. More water along with it. So when there is a blood loss during the PPH, or during the normal vaginal delivery, more and more of the less and less of the RBC is lost and more the other component is lost. That is the reason why nature has provided the pregnant lady to undergo hemodilution. Understand? But what happen in cases of preeclampsia? And preeclampsia, if this is the artery, there will be, there is capillary leakage. So now the fluid will move from the cell to the outside. So there will be hemo concentration. More and more RBC will be present and less H2O will be present. So now if the same amount of blood will be lost, there will be more loss of the RBC and less loss of the other material like water. So same amount of blood loss in cases of preeclamptic lady will lead to a more fall of the hemoglobin. Okay, this is why. So a lot of time what happen if there is a case of severe preeclampsia, you will see that hemoglobin will come out to be 13, 14. But please remember, even a 2 liter of loss will lead to a drastic loss, decrease in the hemoglobin, because this is a very hemoconcentrated blood because of the capillary leakage. Whereas in a normal pregnancy, even a 11 hemoglobin will be good, because a loss of 2 liter from 11 will may lead to 9.5. But in 13 and 14, even loss of 1 liter can lead to 9.5. This is what I'm telling you. So this hemoconcentration that occurs, therefore, earlier uh, uh, there were several indicators for diagnosis of preeclampsia, and hemoconcentration was one of the indicator of diagnosis of preeclampsia. That a lady with hemoconcentration, for example, is hemoglobin at 10 and becomes 11.5, 12, then it was considered then that she may develop um, uh, preeclampsia. But now it has been removed. This is also a new thing, but around 5 to 6 years it has been removed. Earlier, hemoconcentration was an indicator for preeclampsia, but now it has been removed. So this is what I wanted to tell you. Now, what happened to the vasospasm and ischemic sequelae? Now, so this is the third point that you have to understand. Now, this mechanism takes place mainly in the liver. If there will be vasospasm, whenever there will be vasospasm, first thing what will happen? There will be hypertension. So, because of this vasospasm in eclampsia or preeclampsia, you get vasospasm. Second thing is that there will be decreased blood flow. Because of the decreased blood flow, so what will happen? Hepatocyte hepatocyte necrosis will occur. So AST, ALT can increase, and even HELP syndrome can occur. I'll tell you, that is hemolysis, elevated liver enzyme, and low platelet occur. Secondly, because of the hypertension, if the disease further, because of the hypertension, there can be periportal hemorrhages, periportal and there can be formation of hematomas. These hematomas are subcapsular. And if this hematoma size increases, they can cause pain. That is right hypochondrium pain. They can cause right hypochondrium pain, or they can cause epigastric pain. And after some time, you will understand, if a lady of mild preeclampsia develops right hypochondrium pain or epigastric pain, it is now called as severe preeclampsia. There are also indicators, other finding, but this is also one of the finding. Why? Because now the disease has progressed and hematomas are formed, and these subcapsular hematomas, when increases in the size, they will push the capsule of liver. They will push the capsule of the liver, and that will cause what? That will cause the pain. So what is the cause of the right hypochondrium pain? It is the hematomas. And please remember, you can visit sites on the Google, that there are a lot of, this is a very high mortality condition. There are a lot of conditions where hematomas have been formed, and surgeon has just palpated the abdomen, and there has been rupture of the hepatic rupture. Then there is hepatic rupture, and the patient has died even after having the best ICUs and CCUs. Okay, so this is a very bad condition. And what is now HELP syndrome? HELP syndrome is, first is hemolysis, second is increased AST, that is elevated liver enzyme, increased AST, ALT 2 times than normal, that is more than 70, and decreased platelet, that is less than 1 lakh. So how will you diagnose that hemolysis? You will see on peripheral blood smear (PVS). You will see schistocytes. Second, when you will see LDH value will be increased. Okay. Now please remember, in HELP syndrome, PT and INR, APTT, they all they all are within normal range. So this is how you can differentiate it with the DIC. So, and there is a one criteria that is called as TENESSE Tennessee criteria, which say that LDH greater than 600, AST, ALT more than 2 times normal value, and platelet less than 1 lakh. This criteria says that this is diagnostic of HELP syndrome. Okay, so you can this can be just question Tennessee criteria. Okay, so in HELP syndrome, PT, INR, and APTT will remain normal. So this happens in the liver. Okay, now one thing I want to tell you, also because of this vasospasm and ischemia, eyes can be also involved. Eyes can be involved. If they ask you most common finding of eye in preeclampsia, that will be scotoma. That will be scotoma. Scotoma, SCOTOMA. So most common eye manifestation in preeclampsia is scotoma. This is the first question. Second question is, if there will be visual loss, that will be temporary. That will be temporary. Permanent vision loss is very rare. Now, second thing, I have told you, if there will be occipital edema, when I was teaching you pathogenesis of the capillary leakage, then it will be called, and there is occipital vision loss, that will be called as amaurosis. AMAUROSIS, amaurosis. Okay. Now there can be also retinal ischemia, and even there can be retinal cell death, that is retinal infarction in preeclampsia, and that is known as Pursh's retinopathy. PURTSCHER, Pursh's retinopathy. Pursh's retinopathy. This T is silent. That is called as Pursh's retinopathy. This has been asked several times. These all have been asked. All are MCQs. And please remember, till 5 to 6 years back, there was a question that which of the following does not occur in preeclampsia, and the answer to that was retinal detachment. But now it is clear that yes, even retinal detachment can occur. Retinal detachment can also occur. Plus, please remember, if they give you 4 options which does not occur, scotoma, occipital edema, amaurosis, Pursh's retinopathy, retinal detachment, then you can take, because retinal detachment is very rare. Right? To say that retinal detachment doesn't occur in preeclampsia, this is wrong. Retinal detachment can occur in preeclampsia. Okay. So this is vasospasm, hypertension, and hepatic involvement. I told there will be hepatic ischemia and rise in the AST, ALT. That will be called as HELP syndrome. I've explained everything. There can be what? Periportal hemorrhages, leading to the stretch of the liver capsule, which will be responsible for the pain. And there can be right hypochondrium pain or epigastric pain, and patient will be now classified as severe preeclampsia. Severe preeclampsia. Now, severe cases, hepatic rupture can also occur due to hematoma formation. This you have to understand. And eye involvement, I have told you. These are the questions. Most common symptom, it is scotoma. Occipital edema, that is called as blindness, amaurosis. Blindness is generally reversible. If there is retinal ischemia or infarction, that will be called as Pursh's retinopathy, and retinal detachment is rare, yes, but it occurs. So this was regarding vasospasm, and Then third thing I told you, that was thrombotic sequel. So we have a decreased platelet count because the thrombus will be formed. So what will happen? Platelet will be used. So there will be thrombo, and when there will be thrombus formation, that can lead to IUGR and lead to abruptio placenta and DIC. So I have told you the pathogenesis and I have correlated all the complications of preeclampsia with that. Now coming to the management. So first we will understand management of mild preeclampsia. Mild preeclampsia. Now you will tell me that I haven't told you what is mild and what is severe preeclampsia. I will tell you. Okay. So how to manage? So if we have a case of mild preeclampsia, mild preeclampsia. You know that what is preeclampsia? Preeclampsia is that you will have a gestational hypertension with any of the following, that is more than 300 mg protein in 24 hours, or spot sample more than 30 mg per dl, or urine protein creatine ratio more than 0.3 or 1 plus or more protein. That what is mild and what is severe, I'll tell you. So if a patient is of mild preeclampsia, then what you will do? First thing that you will do is you will send the baseline investigation. Send baseline investigation, that is CBC, KFT, LFT, and urine protein. Second, you will try to control the BP. Try to control the BP. Now there are several guidelines that has changed regarding BP, and I will tell everything. But now just write, try to control the BP, because we know that for preeclampsia BP is more than 140 by 90. So we'll try to control BP. Now which drug are to use, which not to use, all the guideline I will tell you after some time. Try to control the BP. Third, we'll see the well-being of mother, that is mother is all right, and well-being of the fetus. How? Through ultrasound and through NST, that is non-stress test. Non-stress test. Non-stress test will show that the heart rate is more than 120. Heart rate of less. We'll study NST in our fourth or fifth lecture. So NST, and with the help of ultrasound, that there is no abruptio placenta, there is no fetal distress, that fetus hasn't passed meconium, everything is all right, mother has a stable BP, there is no everything. So we'll check the well-being. Second thing, what we'll do, in mild preeclampsia there is no role of prophylactic MGSOF. Okay. So these thing will see well-being of the mother, well-being of the fetus. Now, if this happens, now if you are able to control the BP, if you are able to control the BP, if there is well-being, if there's well-being of fetus and mother is ensured, well-being of fetus and mother is ensured, then you will deliver this at 37th week. This is very important. So mild, best time for delivery in mild eclampsia is 37 week. And will you use cesarean section or vaginal delivery? Can anybody tell me, all the people on the Google Meet, can anybody tell me which is the best method? Will you go for the cesarean section, or you can also try for the vaginal delivery, or which one is better? No one is answering. So please remember, always vaginal delivery is preferred. Always vaginal delivery is preferred. In cases of preeclampsia, always vaginal delivery is preferred until and unless there is an obstetric reason for cesarean section. So you will go for the vaginal delivery. So if the BP is controlled, there is fetus and mother is all well-being, there is no problem in them, that we go for the third. If there is convulsions, if there is convulsions, or that means there is eclampsia, or there is HELP syndrome, then you will terminate this is very important because a lot of question is asked. Terminate the pregnancy irrespective of period of gestation. So if there is a convulsion, if even a single convulsion occurs, or if there is a HELP syndrome, then you will terminate the pregnancy irrespective of the period of gestation. This is very important point. Okay, so please remember this. Now, if there is, and I've told you that we'll look for the well-being of mother and father, mother and fetus. And second, what will do, we will see, look for sign of severe preeclampsia. So what, when we'll say that this is a severe preeclampsia, understand this. If there is a severe headache, if the lady start telling that I have very mild headache can be present, if there is a severe headache, is there is a vision disturbance, if there is vision disturbance, okay, if the b if there is right hypochondrium pain, I have told you that means hematoma is forming, or epigastric pain, I have told you that means or there can be dyspnea. Why dyspnea? Because that means lady is having pulmonary edema. So if any of them is present, please remember any of them, that means it is a severe preeclampsia. Any of them is present. Any of them is present. Also, if there is serum creat of more than 1.1, platelet platelet is less than 1 lakh, AST is more than 2 times, or BP is greater than 160 by 110. If any of the four is present, again I am telling you, that means it is a case of severe preeclampsia. Now that they have become a case of severe preeclampsia. Now how to deal with severe preeclampsia, I'll tell you within a time. So I am again just revising very fast. So if there is a mild preeclampsia means BP is less than 160 by 110, but it is more than 140 by 90 along with the significant proteinuria. Now, so we'll send the baseline CBC, KFT, LFT, urine protein. We'll try to control the BP. We'll see the well-being of the mother, fetus through the ultrasound and NST. And we'll look for the sign of severe preeclampsia, because severe preeclampsia has to be dealt in a different way. Now, what we will do, first thing we will control the, if the BP is controlled, there is fetal well-being is ensured, then we will deliver it at 37th week. That means that question that was asked in AIMS, the best time to deliver a child of mild preeclampsia, best time to deliver a child of mild preeclampsia, answer is 37 week, full gestation, and that through vaginal route, until and unless there is an obstetric indication, in the meantime, if there is any convulsion, I think even a single convulsion, or if there is an HELP syndrome, then you will terminate the pregnancy irrespective of the period of gestational. If you go through this chart, you will never miss anything, even in the real life and even in the solving the MCQ. Now, how to, you have to look for the sign of severe preeclampsia. How you will know that the person has severe preeclampsia? These are the 8 things. If the lady tells you severe headache, if any of the is present, any of the below is present, vision disturbance, right hypochondrium pain, epigastric pain, dyspnea, that is pulmonary edema, or serum creatine more than 1.1, platelet more than 1 lakh, AST/ALT more than 2 times, and BP more than 160 by 110 any. So that will be called, that it will be called as severe preeclampsia. And how to deal with the severe preeclampsia? Now I will tell you how to deal with the severe preeclampsia. But before going to, let's revise it through a diagram. So this is, so now understand this very important thing. If there we, so we have understand, if there is mild preeclampsia, best time to deliver is 37 week. If there is a mild preeclampsia, we have understand, this was asked in AIMS examination, best time to deliver is at the 37. If there is severe preeclampsia, that is any of the 8 sign is present, the best time to deliver is 34 week. I'll tell you. I have told you now, if we'll look for the sign of severe preeclampsia, and if severe preeclampsia is present, we will deliver the baby at 34 week. If there is eclampsia or HELP syndrome, then terminate the pregnancy irrespective of gestational period, irrespective of the gestational period. And in case of chronic hypertension, in cases of the chronic hypertension, it is time of delivery should be 38 to the 39 week. These all have been asked questions. Now, management of mild preeclampsia, I have told you, you will send, I have told you where in great detail, baseline investigation you will send, that is you will send CBC, KFT, LFT, and urine protein, and you will try to control the, you will try to control the BP. And what is mild preeclampsia? I have told you what is mild preeclampsia. Mild preeclampsia is, that is BP is greater than 140 by 90 but less than 160 by 110. Because if it is greater than or equal to 160 by 1, that will be called as severe preeclampsia. Okay. Control the BP. Third is watch for fetal well-being through ultrasound and NST. Watch for mother well-being and look for sign of severe preeclampsia. So if sign and symptoms of severe preeclampsia, I have told you, severe headache, vision disturbance, dyspnea, right hypogastrium pain. These 8 signs you have to understand. If BP is more than 160 by 110, serum creatine more than 1.1, platelet less than 1 lakh, AST/ALT more than 2 times. If any of them is present, then it is severe preeclampsia. And best time to deliver then in that case will be 34 week. 34 week. Okay. Okay. Now one thing very important that I forget. Please remember, we have used these 8 criterias to differentiate between mild preeclampsia and severe preeclampsia. But earlier these were total 11 points. There were earlier 11 points. But from those 11, now 8 points are only kept along, because uh, according to the latest Williams obstetrics. And what are those points that has been removed? Now oligouria, IUGR, and proteinuria. They are not. Earlier, if there was oligouria or proteinuria or baby was IUGR, we used to consider that mild preeclampsia case as severe preeclampsia, but now that has been removed. So this can be an MCQ. Which of the following is not a indicator to differentiate mild preeclampsia to severe preeclampsia? So answer will be IUGR, oligouria, and proteinuria. Now, if fetal mother doing well, no sign of severe preeclampsia, then what you will do in mild pregnancy? Terminate the pregnancy at 37 week. At 37 week, you have to terminate the pregnancy in case of the mild preeclampsia. If HELP syndrome or eclampsia occur at any time, then terminate the pregnancy irrespective of gestational age. I have told you. Okay. Now, how will you manage a severe preeclampsia? How will you manage a severe preeclampsia? Now, if there is a severe preeclampsia. I have told you that there are 8 signs that will differentiate a severe preeclampsia for mild preeclampsia, and earlier there were 11 signs. IUGR, proteinuria, and oliguria has been removed. So in case of severe preeclampsia, what you will do? Now you will admit the patient. You will admit the patient. Please remember, in case of mild preeclampsia, we were not admitting the patient. You will admit the patient and you will send the same CBC, KFT, LFT, and urine protein. Okay. Second, try to control the BP. Try to control BP. And third, like that only, well-being of both mother and fetus. Look for the well-being of the mother and the fetus through NST and ultrasound. Second, look for sign of impending eclampsia. That means convulsion. Note, in cases of management of mild preeclampsia, here what we have written, look for sign of severe preeclampsia. And here what we are like, look for sign of impending eclampsia. Third, give steroid if period of gestation less than 34 weeks. This I have already told you. Give steroid if period of gestation less than. But in case of mild preeclampsia, we were not giving steroid. Please remember. And fourth point, now give MgSO4. And here it will be profiling. So these 2 points were not in this point and admit point. This point were not present in case of management of the mild preeclampsia. And at the place of mild preeclampsia, we were not looking for impending eclampsia. We were looking for severe preeclampsia. Now, what are the signs for impending eclampsia? The sign will be more or less same. First will be if there is worsening of kidney function. As we already know that in severe preeclampsia, kidney function is 1.1, but now it is becoming 1.4, 1.8. Then that means there is worsening of the kidney function, and this is one of the sign of impending eclampsia. Second, worsening of liver function. That means AST/ALT further increases. Okay. Or if the baby goes into fetus goes into distress, or there is abruptio. Abruptio is diagnosed through ultrasound. You will see blood that hyperechoic moving masses in the fetus. So that is abruptio. If these are present, worsening or fetal distress, or so that means these are signs of impending eclampsia. What are the other signs? Sign and symptom will be same. That is severe headache. If this lady develops severe headache, and uncontrollable BP. Here, uncontrollable BP. That means you are using everything, NTG, labetalol, even after that the BP is above 160. So these all are basically signs of impending eclampsia. And severe headache, vision disturbance. Now you will say that these were also the sign of severe preeclampsia. Yes, I have told you na, in severe if in mild preeclampsia, any one of the 8 is present, that will be called as severe preeclampsia. And if severe preeclampsia, any of these 8 things is present, it will be called as impending eclampsia. Severe headache, vision disturbance. If this present, there is dystocia is present because of pulmonary edema, or there is right hypochondrium pain or epigastric pain. in any of these impending, you will terminate the pregnancy irrespective of terminate pregnancy irrespective of period of gestation. Termination doesn't mean terminate, you will give medical termination. Terminate pregnancy mean you will do the delivery. And in cases of eclampsia, mild preeclampsia, severe preeclampsia, chronic hypertension, the preferred uh, way of delivery is always vaginal delivery until and unless there is an obstetric indication for cesarean section. Okay, so now, so you will terminate the thing. Also, if in the meantime the lady get any convulsion or develop HELP syndrome, you will again terminate the pregnancy irrespective. Even a single convulsion after, if in the NEET MCQ they say that a lady of preeclampsia developed convulsion, no conservative management. Terminate the pregnancy irrespective. Develops HELP syndrome, terminate the pregnancy. Develops any of the impending eclampsia, terminate the pregnancy. Now, what is the difference? You will say that if the lady has severe headache, you will terminate the pregnancy. No, if the lady of I have this is in case of severe preeclampsia. If the lady has mild preeclampsia, we will consider it as a severe preeclampsia. If she develops severe headache, we will admit the patient and we will do all those things, and then headache will be gone. So that means now we can continue. We can continue. But if the lady has severe preeclampsia and even after doing everything his headache is not going, then she may land up into the cerebral hemorrhage. Then that will be a sign of impending failure. So the symptom is same, but the background is different. In mild preeclampsia, we will consider it as a severe preeclampsia, and in severe preeclampsia, we will, even after the management, if the headache is not going, then we will consider it as a sign of impending convulsion. Then we will try to, then we'll terminate the pregnancy. Okay, this is the difference. Now, so best time to terminate the best time for delivery in severe preeclampsia is 34 weeks. If everything is going good, that means BP is controlled, fetus and mother well-being is ensured, no sign and symptom of impending eclampsia, then you will do the delivery at 34 weeks. But in between, if there is impending eclampsia or if there is convulsion or help, you will terminate the pregnancy. So this is how you will manage cases of. Okay, so now see this. So same patient, now you will admit the patient. In case of severe preeclampsia, this is the difference. Send baseline, this will be the same. Control of the BP, watch for fetal well-being, watch for mother well-being, look for impending eclampsia. And what are the signs of impending eclampsia? Severe headache, vision problem, pulmonary edema, right hypoxia. These are same which earlier we have seen. Now, if there is uncontrollable BP, worsening kidney and liver function, or placental aberration or fetal distress, terminate the pregnancy irrespective of period of gestation. Okay. And if there is, I've told you, if there is HELP syndrome or eclampsia, terminate the pregnancy. Okay, so if a lady of so if a lady of severe preeclampsia, even after management, is having headache, which is severe headache, and you are not able to manage it and it's going on, then you have to terminate the pregnancy because she may develop cerebral hemorrhage. Okay, this is the difference. But in a lady of mild preeclampsia having severe headache, you will not. You will admit the patient. You will try to control the headache. You will give MgSO4, you will give steroid, you will give uh, try to painkillers and everything. So, okay, so this is the difference. So symptoms remain same, but background is different. That is what it written in the Williams obstetric. Now coming to the antihypertensive drugs. This is very important point. Now, that if I ask you what is the drug of choice, the drug of choice is labetalol. Labetalol. It can be given orally, it can be given IV. Okay. So what is the drug of choice? Levodopa. What are the other drug that you can give? You can also give alpha methyl dopa. If they ask you which is the safest drug, then your answer will be alpha methyl dopa. So if they ask you which is the drug of choice, answer is labetalol. Which is the safest drug? Answer is alpha methyl dopa. Other drug that you can use is hydralazine. Hydralazine. And what else you can use? You can use nifedipine. Nifedipine oral, not sublingual. Okay, these are the drugs. So what is the dose of? Now please remember chronic use of labetalol. Chronic use of labetalol can cause IUGR. Otherwise, it is a very safe drug. So if they ask you in drug of choice in preeclampsia, eclampsia, chronic hypertension, it will be labetalol. But if they ask you safest drug, methyl dopa. And unless labetalol was introduced, this was the drug which was being used for 20 to 30 years, from 80s, 90s, and 70s. Now, if we talk of the doses of labetalol, so IV, how to use? First, it is given 20 mg. Okay. Then we wait for 10 minutes. If BP is controlled, now first of all, when to give drug? I have told you whenever the BP is more than 140 by 90, that is called as a preeclampsia. If there is there is proteinuria, but we don't start antihypertensive drug. According to the American European guideline, they start drug at BP more than 160 by 110. But in India, according to Government of India, we start antihypertensive drugs when the BP is more than 150 by 100. Please remember this. The American guideline, European guideline, Australian guidelines say start antihypertensive after 160 by 110. But Government of India say start once the BP is more than 150 by 100. Okay. So this is, so we give the 20 mg, then we wait for 10 minutes. If BP doesn't come to normal range, then we will give 40 mg. If it again doesn't come to, then we'll wait for 10 minutes, then we will give 80 mg. If it doesn't come to normal, then we will again wait for 10 minutes, and if it doesn't come to normal, we'll again give 80 mg. So we are giving 80 plus 80, 160, 200. So we can give 220 mg in a single sitting. So if they ask you what is the maximum dose in a single setting, it is 220 mg. But if they ask you maximum IV dose, IV in a day, in a total day, then it is 300 mg. But in a single setting, you cannot give more than 220 mg. Okay, and this is the way how it is given, which is how it is mentioned in the Williams obstetric, and it is also given practically like this. Now, oral labetalol, when we give oral, we start at 100 mg TDS, and then we can increase the dose, and the maximum permittable dose is 1200 mg per day. But please remember, chronic use of labetalol can cause IUGR, but in spite of that, it is used a lot. Now coming to the second drug, alpha methyl dopa. Alpha methyl dopa, the dose is 250 to 500 mg, 6 to 8 hourly. And maximum dose that you can give is 2 grams. Maximum dose is 2 gram. Hydralazine, the dose is 25 to 50 mg, 6 to 8 hourly, and the maximum dose is 300 mg. Nifedipine we use orally, that is 10 to 20 mg, 8 to 12 hourly, and maximum dose is in a day is 120 mg. Okay, so please remember this maximum dose. Okay. Can anyone tell me the name of that drug whose maximum dose was 2 mg? in a day, used in obstetrics, especially in the OTs? Can anybody tell me on the Google? Oh, no one is there. So this is carboprost. 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 The maximum dose that you can give in a day is 2 mg, because a single day the dose is 250 microgram and you can give it 8 times. So total dose that you can give is 2 mg. Okay, so nifedipine. Please remember, sublingual nifedipine can cause dangerous hypotension. Can cause dangerous hypotension. Can cause dangerous hypotension. So it has to be avoided. So it is avoided. So these are the drug that when to give the drug and what are the drug that you can give. Now if I ask you, which drugs you cannot give. So please remember ARBs, ACE inhibitors, diuretics, diazoxide, DIAZO diazoxide. Earlier there was drug reserpine but not used. Reserpine, sodium nitroprusside. These all drugs are contraindicated. These are contraindicated. Okay. ACE inhibitors and ARB. So if they are contraindicated, you don't need to know the doses. Uh, ARB and ACE inhibitor, they can cause what they can cause? They can cause limb contracture. They can cause bone deformities. They can cause respiratory distress syndrome by decreasing surfactant formation. They can cause persistent ductus arteriosus, persistent ductus arteriosus. These are the things that they can cause. Now, although diuretic is contraindicated, but there is a single area where we can give diuretics. Can I? Oh, there is no one. Uh, in case of pulmonary edema, in case of pulmonary edema in pregnancy, you can use diuretic, but you cannot use diuretic to lower down the blood pressure. Okay, so diuretic is contraindicated as an antihypertensive. It can be used only in case of pulmonary edema. So this was regarding the antihypertensive drugs. So see, when to start antihypertensive drug, I have told you. When to start if it is more than 161 by 10. This is told by the American and European guideline, but nice guideline, and what is followed in India, it is more than 150 by 100. I have told you. Okay, drug used are labetalol, alpha methyl dopa, hydralazine, and nifedipine, but not sublingual. Drugs contraindicated: ACE inhibitors, ARB, diuretic, but can be given in pulmonary edema, diazoxide, beta blocker like propranolol, metoprolol, and labetalol. I have told you 100 mg TDS and can be given to 1200 mg daily in 3 divided dose, and it can cause IUG. Labetalol can cause IUGR. See, this is I have written here. Alpha methyl dopa. This is the dose 250 to 500 mg 6 to 8 hourly, 2 gram maximum dose. Hydralazine. It is 225 250 mg 6 to 8 hourly, 300 mg maximum dose. Nifedipine we give orally. It comes by the name of Nicardia, very common drug. 10 to 20 mg, 8 to 12 wali, maximum 120. So this is what you have to understand. Now this I have told you, these are the drugs that you cannot use. Please remember, non-selective beta blocker like propanol should not be used. because they can also block the beta 2 receptor, and that can cause vasoconstriction. And ladies already respiratory compromise, so we cannot afford it. So, and they can also, so this is the main reason. So non-select, so ACE inhibitors, ARB, digoxin, digoxide, sodium nitroprusside, and non-selective beta blocker like propanol. These drugs cannot be used. Okay. And these are the complications which I have already explained you. Now, what are the danger of eclampsia? So please just remember, it can danger of eclampsia. I just see it can cause cerebral hemorrhage, cardiac arrest, aspiration, pulmonary edema, kidney failure, blindness, abruptia. So this we have already told. There was a question which was asked: what is the most common cause of death in eclampsia? So answer will be cerebral hemorrhage. Answer will be cerebral hemorrhage. Most common cause of death. Most common cause of death. If they ask you most common cause of death in uh, eclampsia, it is the cerebral hemorrhage. Now, MgSO4, this you have to understand very, because a lot of questions that are asked in on it. Now, MgSO4, first understand the dosing. So there are two kind of first understand the vial. The ampule of MgSO4 consists of 2 ml. It is contains 2 ml. It is 50% solution. 50% means 500 mg per ml. So in 2 ml there is total 1000 mg of magnesium sulfate, that is 1 gram. So these are so each ampule contains 2 ml, that is total 1000 mg, that is 1 gram, and it is 50%. Now the first tech is way is to give is Pritchard regime. Pritchard, Pritchard regime. Pritchard regime. Pritchard regime. What do you do in Pritchard regime? Initially, you prepare a 20% solution. If even you make a 20, how you make? You take 4 ampoules of MgSO4. 4 ampoules of MgSO4. 4 ampoules means you have taken 8 ml, or you can say you have taken 4 gram of MgSO4. All are same thing. Plus you will add 12 ml of NS. So this is total 20 ml of solution is made. Total 20 ml of solution is made, and this is 20%. Now what you will give? You will slowly give IV over 5 to 10 minutes. Over 5 to 10 minutes. Then you will give 5 gram IM in each buttocks. In each buttocks. This is the complete loading dose. This is the complete loading dose. Please remember, this is the complete loading dose. So how much loading dose you have given? You have given initially 4 gram, then you have given 5 gram on each buttock. So total you have given 14 gram in loading dose. And then followed by what you will give? 5 gram 4 hourly in each buttocks IM. So this is, so initially you give 14 gram and then 5 gram intramuscularly every 4 hourly. This regime is known as Pritchard regime. So please understand what is the percentage we give, how much we give. Second is Jaspan regime, Juspan, Jaspan regime. In this we give IV. Initially we take 4 to 6 gram of MgSO4 and put it in 100 ml NS. Give it slowly over 15 minutes, and then it is followed by 1 to 2 gram per hour. Now there is a very important thing. This you have given, you know the dosing, everything. Till when you have to give? You have to give MgSO in cases of eclampsia. I am telling you, that is if there is convulsion, You have in books there is a line written that you have to give 24 hours after the delivery or after the last convulsion, whichsoever is latter. What does this means? This means that we know that eclampsia, that means convulsion. Eclampsia or convulsions, they can be of three types. They can be antepartum, that means they can occur before the delivery. There can be intrapartum and they can be postpartum. Sorry that I am writing in this way. Now, there are two questions in it. Which of them has worse prognosis? So please remember it is the antepartum which has the worst prognosis. Antepartum eclampsia has the worst prognosis. Antepartum eclampsia has the worst prognosis. Why? Because the lady has convulsion. Now you will take the lady to the OT and then you will deliver. So in the meantime, a lot of things can happen. As we have already studied the slide, the dangers of eclampsia, that it can go cerebral hemorrhage, pulmonary edema, aspiration, cardiac arrest, kidney failure, urine output, decrease urine, anything can happen. Everything can happen. So antepartum, so the worst, therefore, this during this time a lot of thing can happen. Whereas in intrapartum, what happened? In cases of the intrapartum, there is patient is already in the delivery in the hospital, in the labor room or in the OT. So there are people like anesthetist, obstetrician all around. So you have time. Similarly, postpartum generally occurs within 48 hours after delivery. If a seizure is occurring after 48 hours of the delivery, then other causes of seizure should also be taken. Therefore, the worst prognosis is of antepartum seizure because the complication has a lot of time. Their intervention occurs after some time and therefore complications can creep in. Now, what I was telling you, so in cases of antepartum hemorrhage or intrapartum or postpartum, till when you have to give MgSO4. So you have to give MgSO4 24 hour after the seizure, after the last seizure or the delivery, whichever is the latter. That means in cases of antepartum hemorrhage, that means hemorrhage has occurs. So I'll make a new slide. So in case of 10. Now in case of we have antepartum, we have intrapartum, and we have postpartum. So in case of antepartum, we'll give the MgSO4 till how much time? In case of intrapartum, in case of postpartum. So if it occurs in the intrapartum period, then it says that you have to give 24 hours. So you will give till 24 hours after the delivery. Okay, for example, delivery occurs on the 9 a.m. on 24th of some month. So you have to give till 9 a.m. next day, that is 25th. In case of postpartum, that in the same patient delivery has occurred in the 9 a.m., but you will now not calculate from the 9 a.m. If the seizure has occurred on the 10 a.m. of the 25th, although the delivery has occurred on the 9 a.m. of the 24th, then when you will give, you will calculate now 24 hours from this. So you will give till 10 a.m. 10 a.m. at till date 26. Date 26. Okay. So in case of intrapartum, you will calculate the 24 hours from the time of delivery. In case of postpartum, you will calculate from the last seizure, when the seizure occurs. So that is why they write that you have to give after the delivery or after the seizure, which is latter. And in case of antepartum, you will, when you will give, now seizure has occurred, for example, on the 22nd date at 9 a.m. But delivery has occurred on when? Delivery had occurred on 10 9 a.m. So now you will calculate from this 9 a.m. So you will give till 9 a.m. and date will be 25. This what I will. So simply this you have to understand that you have to give MgSO4 uh, 24 hour after the delivery or the seizure, whichsoever is latter. So in case of intrapartum, what you will do, you will calculate from the delivery. In case of postpartum, you will not calculate from the delivery, you will calculate from the seizure. Okay, and case of antepartum, you will again calculate from the delivery, from the time of delivery. Okay, so this was regarding MgSO4. Now MgSO4 is contraindicated in three areas. If there is second and third degree heart block, you don't have to give. In case of myasthenia gravis, in case of myasthenia gravis, and other condition in case of renal failure. Okay, so in these are the contraindication where you please remember, because they can be asked as a neat MCQ. Now, whenever you are giving MgSO4, whenever you are giving MgSO4, you have to lick 4 point before giving the next dose. And you will always give the next dose when all the 4 points are present. That is, saturation should be more than 96%. Respiratory rate should be more than 14. Urine output should be more than 30 ml per minute. And patellar reflex should be present. Patellar reflex should be present. When these all four findings are present, then only you will repeat the next dose of the MgSO4. Otherwise, you will not repeat the next dose of the MgSO4. And what is the antidote of MgSO4? Antidote of MgSO4, it is calcium gluconate. It is calcium gluconate. And here you have to follow the rule of 10. What is rule of 10? 10% of calcium gluconate, 10 ml over 10 minutes. Okay, this is how. So this is how you have to give the antidote. So now if the all the 4 points will be present, then only you will give the MgSO4. Please remember this. Okay. Now I'll ask you, what is the mechanism of action? So I've told you it is NMDA antagonist. It is NMDA antagonist. So it prevents glutamate induced seizure. It causes cerebral vasodilation. Third, it decreases acetylcholine release in neuromuscular junction. Second, sorry, it increase acetylcholine release in neuromuscular junction, increase sensitivity of acetylcholine to acetylcholine receptor in neuromuscular junction. Now, this is very important point. When you give MgSO, initially when 1980s or when MgSO4 was invented, was discovered, made, so, and it was given in eclampsia, so most of the researchers said that because it increases this, sorry, it decreases the acetylcholine release. I am really sorry. And increases the sensitivity and decreases the sensitivity of acetylcholine to the so most of the researchers used to say that since this decreases the acetylcholine release in the neuromuscular junction and decreases the sensitivity of acetylcholine to acetylcholine election, so it causes muscle relaxant, and it is actually a muscle relaxant, so it doesn't help in convulsion. It helps in convulsion. Is just this is just a superior aspect because it is relaxing the muscle, so we are seeing that it is treating the convulsion, but actually it is just a muscle relaxation. And just like succinylcholine or normal vecuronium and rocuronium, it is simply relaxing the muscle, so it is not. So please remember, there was a 8 to 10 years gap where MgSO4 use was not used, because people used to consider it as a muscle relaxant, because it is decreasing the acetylcholine, it is decreasing the sensitivity of acetylcholine receptor. But then again researches took place and it was found no, it is also an MDA antagonist, it is also cerebral vasodilator, and it is also a calcium antagonist. It is a calcium antagonist. So decreases decreases capillary leakage. Now I will explain you what this is. So these are the five mechanism of action. So understand. And please remember, that's why when anesthetist gives uh, a general anesthesia to a person who is on MgSO4, the dose of muscle relaxant is low. Why? Because MgSO4 decreases acetylcholine release and it decreases sensitivity of acetylcholine. So it away, yes, it acts like a muscle relaxant. So the dose of actual muscle relaxant like vecuronium will be less. Okay. This is one of the other point. Now what happened is this is the artery and this is the endothelium. Now you know that endothelium retracts. For example, it will become like this. And this retraction occurs because of the calcium. And then there will be a increase in the endothelial gap will increase and there will be leakage. So when you will give magnesium, what happens? Magnesium will is a and it is a physiological antagonist of calcium, so it will prevent this calcium, this endothelial retraction, so it prevents the capillary leakage, so it prevents the edema formation. That is why it is used in the prophylaxis of the severe preeclampsia to prevent eclampsia, because it is a calcium antagonist. So please understand these things. Okay, it acts as a calcium antagonist, so it prevents calcium induced endothelial retraction, so it decreases the endothelial gap and so it prevents the capillary leakage. That is why it prevents the convulsion or the eclampsia in case of severe preeclampsia. Okay, so this is why if someone asks you why you give MgSO4 as a in severe preeclampsia as a prophylaxis, this is the reason. Okay, so this is MgSO4. I have told you everything about. Yes, one more thing that is left is the MgSO4. The normal value of MgSO4 is 1.7 to 2.4 mg per dl, or 1.5 to 2 milliequivalent per liter, or zero point 0.7 to 1 millimoles per liter. Then if they ask you what is the therapeutic value, that is the value in blood to deal with the preeclampsia and eclampsia, it is 4 to 7 milliequivalent per liter. At 8 milliequivalents per liter, patellar reflex start decreasing, and at 10 milliequivalents per liter, patellar reflex is lost. Please remember. Similarly, at 12 milliequivalents per liter, respiratory depression starts, and at 15 there is complete respiratory paralysis. There is complete respiratory paralysis, and at 25 milliequivalent per liter, there will be cardiac arrest. There will be a cardiac arrest will occur. So now what are the places where you will use MgSO4? I have told you you will use as a prophylactic in where? In the severe preeclampsia and in HELP syndrome. And the reason is because it is calcium antagonist and it prevents the capillary leakage. Second, it is used in eclampsia, that is in convulsion, because it is an NMDA antagonist. Okay. Third, it is also neuroprotective. The exact reason is not present. It is neuroprotective. Hence, it is used in preterm deliveries. It is given in preterm delivery to mother, and it decreases the incidence of cerebral palsy. So this can be asked as one of the question. So MgSO4 is a neuroprotective agent, and in preterm delivery it is given to mother in lot of centers to prevent cerebral palsy. So this is regarding the MgSO4. I think if you know this much about MgSO4, you know each and everything. Now, so I've told you this is the loading dose, 4 gram 20%. I have told you it is 20%. Slowly IV, followed by 10 grams of MgSO4. 10 grams, that is 5 gram in each buttocks. So total dose will be 14 gram. That is the loading dose. Then maintaining dose given after every 4 hours, 5 gram, 50%. So please remember that maintenance dose is given as 50%. We don't dilute. Whereas when we are giving loading dose, we are diluting. It is making into 20% because it has a lot of side effect. That's why we are giving a 20%. Then this is a Jaspan residue, 4 to 6 gram in 100 ml NS slowly over 30 minutes and followed by 1 to 2 gram per hour. What are the contraindication? I have told you myasthenia gravis, deranged renal function, and second and third degree heart block. First degree heart block you can give. It blocks NMDA. Now it blocks NMDA receptor, cause cerebral vasodilation, block the calcium channel, decreases intracranial edema, and also fourth and fifth, that is decreases the acetylcholine release. It also decreases the sensitivity of the acetylcholine receptor towards acetylcholine. So muscle relaxation dose is decreased when general anesthesia is given to a patient having MgSO4. Monitoring, I have told you urine output should be more than at least 30 ml per hour. Deep tendon reflex should be present. Respiratory rate should be more than 14. Pulse oximeter itna. Repeat injection are given only and only if all of the above are present. If any of these are absent, maintenance dose is omitted. Maintenance dose is omitted. Please remember, this is what I have told you. Now MgSO4 continue. So I have told you in eclampsia we have antepartum, intrapartum, and postpartum. Which has the worst prognosis? Antepartum. When MgS4 given till 24 hour after the seizure or after the delivery. In intrapartum, give 24 hour after the last seizure. And in antepartum, what you will give? You will give after the delivery, 24 hour after the delivery. It doesn't, now you will not, in antepartum, you will not count from the seizure. You will count from the delivery. For example, if the seizure occurs 6 hours before the delivery, it doesn't matter. We will count from the delivery. This initial 6 hour will not be taken into account. Then normal value, I have told you 0.7 to 1 millimoles or 1.5 to 2 milliequivalent per liter or 1.7 to 2.4 mg per dl. Please remember this value, milliequivalent per liter. And in 8 patellar reflex start decreasing, and in 10 patellar reflex is lost. 12 respiratory depression starts, and 15 respiratory arrest. 25 we have cardiac arrest. All this has been asked in a question. Other uses, prophylaxis. It is used in prophylaxis of severe preeclampsia or prophylaxis of HELP syndrome, then treatment of eclampsia, and neuroprotective in cerebral palsy in cases of preterm labor. So these all points I have explained you very indeed. Now, what are the risk factor of the preeclampsia? So history of preeclampsia. If there is a history of preeclampsia, then that is a risk factor. In obstetrics, most of the things, for example, if you have history of ectopic, then that is a risk factor. Okay. So history of preeclampsia, then primiparity. If the lady is becoming first time pregnancy, that is itself is a risk factor for preeclampsia. Then extreme of ages, extremes of ages, that is less than 18 years. If the lady becomes pregnant at extreme of ages, that is less than 18 years or more than 35 years. That is also, they say if there is increase inter-pregnancy time, that we generally say that between two pregnancy there should be 3 years of gap. But if the gap is more than 6 years, then that is also a risk factor for preeclampsia. Then obesity itself is a risk factor. Then multiple gestation. Then molar pregnancy. In molar pregnancy, we have seen that preeclampsia can be there because it can secrete beta HCG. Then, if the lady has diabetes, chronic kidney disease, EPLA syndrome. In EPLA syndrome, we have studied modified Shapiro classification. EPLA syndrome is a risk factor for the preeclampsia. So you have to remember this list. And yes, and chronic hypertension. If the lady has chronic hypertension, he has a tendency that he can develop preeclampsia. Now, predictors of preeclampsia. I have told you there were some predictors earlier. There were some predictors which were used. For example, hemo concentration. If the lady used to have hemo concentration, they used to say that this lady will develop preeclampsia, and I have told you the reason for this. Second, if there is increased uric acid, then they say that lady will have preeclampsia. If there is increased homocysteine in blood, then they used to say that the lady will have preeclampsia. And if there is decreased urinary excretion of calcium, this is then there and positive rollover test. Now please remember, you don't have to remember these things. Why? Because they have been removed from the New Williams Obstetrics and the most of the books. Now they are not considered predictors of preeclampsia. Now what is considered? The ultrasound. We look, especially Doppler ultrasound, we look for diastolic notch in uterine artery. Practically, this is the thing that is used. And then there are also new predictor which have come. I will tell you. So what happen if we are doing Doppler of the uterine artery during systole, this will be like this, and then there will be diastole like this. Then again there will be systole, and then there will be diastole. So there will be this notch. This notch is called as diastolic notch. This notch is called as diastolic notch. This notch is known as diastolic notch. So this notch is initially present till 22 to 24 week. This notch is present. Why? Because no, initially the spiral arteries, I have told you, the decidua basalis, they slowly increase their width, increase their diameter. So more and more blood start accumulating in them. So what happens? So pressure inside them increases. So this notch that we are seeing, this is after some time this notch is gone and it appears like this. So there is no notch. So this notch, so this happens in a normal pregnancy, that this notch is gone because of the increase blood content in the spiral artery. But what we have seen in the pathogenesis, now understand and revise that pathogenesis, we have seen that in spiral arteries are not able to convert into loose vascular channels. The blood in them is very less. So what happened? Now this notch is still is present because of less blood, less pressure. So what happened? If the notch is present, if notch is present after 22 to 24 week, then it is a indicator of preeclampsia. Okay, so if you ask you what is the best indicator, now it is the notch, present of diastolic notch after 22 to 24 week in uterine artery Doppler is the best indicator. Now understand, there are certain factors which have come. Now we know that there are when the uterine artery is formed, there is trophoblastic invasion, new arteries are formed. So there are two factors. One is angiogenic factor, angiogenic factors, and others are anti-angiogenic factor, angiogenic factors. Angiogenic factors helps in the proper remodeling of the artery. So if there is a decrease in the angiogenic factor, that can cause preeclampsia, and if there is increase in the anti-angiogenic factor, that can cause preeclampsia. So what are the angiogenic factor? It is vascular endothelial growth factor and placental growth factor. So decreased vascular endothelial growth factor and decreased placental growth factor are also an indicator of predictors of preeclampsia. Please remember. And what are angiogenic factors? Angiogenic factor, please remember, soluble FMs like tyrosine kinase. This is new. And second is endoglin. Endoglin. So if they are high, because they are, so that they are also pre. So a decrease in angiogenic factor, that is decrease in vascular endothelial factor and platelet growth factor, are a predictors of preeclampsia, and an increase of anti-angiogenic factor, that is soluble FMs like tyrosine kinase and endoglin, endoglin, are predictors of preeclampsia. So what is endoglin? Endoglin, please remember, a lot of research is being done on endoglin. Endoglin basically inhibits nitric oxide mediated vasodilation. Second, it is also an inhibitor of TGF beta. If you want, you can write, but I don't think they will ask you this. You have to just remember that endoglin is increased. Increased endoglin is a predictor of preeclampsia. I'm writing here endoglin. What it does, it prevents nitric oxide mediated vasodilatation. It prevents nitric, and secondly, it inhibits TGF beta. TGF beta. Okay. So it is an anti-angiogenic factor, and increase of endoglin is a predictor of a, and similar is a FM like tyrosine kinase. What does FM like tyrosine kinase do? It is a inhibitor of vascular endothelial growth factor and placental growth factor. So these are the predictors which you should know. Now, non-preventive, please remember, early there are certain things which are not preventive. So the things which are not preventive, you have to know. This is asked in questions, plus you can also advise it to the people. Salt and water restriction. Salt and water restriction has no benefit, well, of no benefit in preeclampsia. Salt and water restriction has no benefit in preeclampsia. Antioxidants has no role. Okay. Vitamin A, C, and E, no role. Fish oil, there is no role. Heparin alone, no role. So please remember, all those things will have no role. So what are the things that you can be used? Please remember, aspirin. Aspirin plus minus heparin. This is preventive. Calcium supplementation. But there is calcium supplementation is preventive. But there is a kick in it. Calcium supplement is only if serum calcium is low, that is less than 8 gram per day. Okay, so calcium supplementation is only preventive. If the calcium is normal, 8 to between 9 to 11 mg per day, then there is of no use. Third is exercise, mild to moderate. Now, fourth point, I don't want that I should write, because I am writing here, but please don't tell anyone. Smoking is preventive. So if they ask in your MCQ, smoking is preventive. Smoking is preventive in Alzheimer's disease. Smoking is preventive in ulcerative colitis. Smoking is preventive in hepatocellular carcinoma. Smoking is preventive in endometrial carcinoma, endometrial hyperplasia. Smoking is preventive in preeclampsia. Okay. So a lot of place smoking is preventive. Okay. These are non-preventive. Now diabetes in pregnancy. Now just give me 5 minutes, then we will start diabetes in the pregnancy. मुझे क्या करना है? मैंने अभी माइंड में एकदम वो मत करो बाबू. So let's start diabetes in pregnancy. Now, see, first we have to understand the pathophysiology. Now, what happened? There are four hormones which we have to understand. Four hormones. These are human placental lactogen, cortisol, estrogen, and progesterone. These increases the they increases the insulin resistance. They increases the insulin resistance in mother. They increases the insulin resistance in mother. So when insulin resistance increases, what will happen? Glucose will not be able to move inside the cell, so there will be hyperglycemia. There will be hyperglycemia in mother. There will be hyperglycemia in mother. And this why? So why nature has made it? Because this glucose will be utilized by this glucose will be utilized by fetus, because fetus doesn't get glucose from any other source. Now, so this hyperglycemia in mother, so there is more secretion of HPL, cortisol, estrogen, progesterone, and there is increased insulin resistance. There is hyperglycemia in mother. So glucose will be utilized by the fetus. Now, please understand, since there is hyperglycemia in mother, but there is also insulin resistance. So the mother is not able to utilize this glucose. So there is further feedback. So there is more insulin release in the mother. Please remember, the insulin cannot cross the placenta. Insulin cannot cross the placenta. Okay. Now, so there will be more insulin. Now, so what will happen? This fetus will use this glucose. So when the mother will sleep and will get up, so there will be what? There will be fasting hypoglycemia in mother. There will be fasting hypoglycemia. There will be fasting hypoglycemia in the mother. Why? Because she is not the insulin, there is increased insulin resistance, so glucose is not getting inside the cells of the mother. But on the other hand, fetus is continuously taking the glucose, so there is fasting hypoglycemia, and there is postprandial hyperglycemia, because when mother will eat, because of insulin resistance, she will not able to use the full glucose. So these are the two things which happens. Okay, this is a normal thing that happen. Now this, but if there, but if we see fasting hyperglycemia in a mother, fasting hyperglycemia in mother, that is abnormal. Fasting hyperglycemia is abnormal. This is first point. Now understand very important pathogenesis point. When when does baby start producing insulin? This was a question. So baby start producing insulin at 12th week. At 12th week, baby start producing insulin. And till 12th week, how the glucose enters into the baby cell? It is through GLUT1 and GLUT3. This has been asked. This has also been asked that baby start producing insulin after the 12th week. Now, hmm, now there is, when the mother is becomes diabetic, please remember, when the mother becomes diabetic, more and more glucose enters into the fetus. So fetus produces more insulin and more insulin. And what does that insulin causes? that insulin causes, we know that insulin is a anti-lipolytic hormone. It causes fat deposition. Fat deposition. So there is fat deposition into the fetus, and fetus weight increases and lead to macrosomia. Lead to macrosomia. Also, this insulin insulin has a, in the pregnancy, insulin also has a act like a growth factor, and it increases the bones and the muscles of the baby. This is called as Penderson hypothesis. Penderson hypothesis. I am giving time on this because you will understand why. Because this will help you in understanding and remembering the complication. So this is called as the Penderson hypothesis. Now this increased insulin in the baby. So you understand why there is increased insulin in the baby. Why? Because there is too much glucose. The mother is diabetic. There is increased insulin resistance, and mother is not able to take glucose. So more and more glucose is coming in to the fetus, and this glucose is increasing the insulin production by the child after the 12th week, and that is causing the fat deposition leading to the macrosomia, or also the overall growth, because insulin act as a growth factor. This is known as Penderson hypothesis. This insulin also inhibits, please remember, this insulin also inhibits the surfactant. Therefore, thus this baby can also develop respiratory distress syndrome, can also develop the respiratory distress syndrome. Now, when this baby will be born, please understand, there will be more insulin in his blood or in her blood, but the glucose will not be there because now the connection from the mother is cut. So what will happen? This increased insulin will lead to neonatal hypoglycemia. Neonatal glycemia. This you have to understand. So this is what you have to understand, that why macro, the all the culprit is in the mother, the hyperglycemia in the mother, and insulin release and insulin resistant in the mother, because of this hyperglycemia, this glucose is going to the fetus, and fetus is increasing the insulin, which is causing the fat deposit leading to macrosomia, acting as a growth factor and causing increased growth of the baby by Penderson hypothesis. And insulin is decreases surfactant production, so respiratory distress syndrome. And when the baby is born, there is more insulin, less glucose, leading to neonatal hypoglycemia. So this is the pathophysiology which you have to understand, and we will again come to this pathology. Okay. Now there are two type of diabetes. One is overt diabetes, and other is gestational diabetes. Please remember, insulin resistant is maximum at 24 to the 28 week. Insulin resistance is maximum at 24 to the 28 week. Insulin production in the fetus starts at the 12th week. Insulin resistance in the female is maximum at the 24 to the 28th week. Now, what is over diabetes? Over diabetes means that the lady was having diabetes and then she became pregnant. And gestational diabetes means that the lady becomes pregnant and then she developed diabetes as a complication of the pregnancy. And this gestational diabetes generally occurs after 24 weeks. And over diabetes, that is, she was already uh, already having diabetic. Now, which is more dangerous? Please remember, overt diabetes is more dangerous. Over diabetes is more dangerous. Why? Because in over diabetes, the lady was already having diabetic. Now, there was increased sugar. There was increased sugar. So, because of the increased sugar, there was increased free radicals. Oxygen radicals were formed, and in the initial 0 to 12 week there is organogenesis, so these radicals will inhibit the proper organogenesis, whereas in case of gestational hypertension, the hyperglycemia occurs after the 24 weeks, so most of the organs are already formed, so generally you will not see the congenital deformation in gestational diabetes. So in over diabetes you will see two special complications. One is the congenital malformation, congenital malformation, and the reason is boss, because the reason is that because the lady is already diabetic, she is already having more glucose, so she is already having the more radicals, whereas in case of gestation the organogenesis have already developed before the development of the organs have already developed before the development of the diabetes. Now, congenital malformation and abortion, these are the list you will see in the over diabetes. Now, how to diagnose over diabetes? An HbA1c of more than 6.5%. Okay, on fasting glucose of more than or equal to 126 gram per dl, random blood sugar of more than 200 mg per dl along with signs and symptoms, or 100 gram glucose tolerance test, you get more than 200 mg per dl after 1 hour. So if any of them is present, for example, a lady at 14th week enters to you and you see HbA1c of 8%, that means she is over diabetes. And now also remember the risk of congenital malformation in overt diabetes, OVERT, is directly proportional to HbA1c. Is directly proportional to HbA1c. This has been asked. More the HbA1c in overt diabetes mellitus, more will be the risk of congenital malformation. But this is not the case in case of gestational hypertension, because I have told you the reason. Now, this is I have told you. Now, how to diagnose gestational hypertension? This is very important. Now, for diagnosis of gestational diabetes, we have one is the guideline given by American College of Gynecology. That is a two-step process. I am telling you just for the neat purpose, because in India you cannot go for a two-step process. What is the two-step? There is one. First step is known as glucose uh, challenge test. First is the glucose challenge test, and second test is the glucose tolerance test. Glucose tolerance test. In glucose challenge test, you will give 50 gram of dextrose. In glucose tolerance test, you will give 100 gram. Here, no fasting is required. Here, no fasting required. Here, fasting is required. How much hour? 8-hour fasting is required. Here, no fasting sample is taken. No fasting sample is taken. And here, fasting sample is also taken. Fasting sample means after 8-hour fasting, you have to take the sample. So in case of glucose challenge test, you will give 50 gram of dextrose. No fasting is required. No fasting is sample is taken. And after 1 hour, you will do the blood sugar. After 1 hour. Please remember, after 1 hour, blood sugar. And if it is less than 140, then you will say no diabetes. If it is 140 to 180, then you will say that screening test is positive. Screening test positive, you will go on to the next step, glucose tolerance test. If it is 180, you will say diabetes present. No need of glucose tolerance test. Okay. So if this screening test is positive, you will go for the glucose tolerance test. What happened? You will give 100 gram, fasting 8 hours, and fasting sample is taken. Now, you have to follow here Kauston and Carpenter classification. Carpenter classification. Carpenter classification. Kauston and Carpenter classification. It says it gives you 4 fasting value, then 1 hour, 2 hour, and then 3 hour. Fasting means after 8 hours. Then after 1 hour, then 2 hours, then 3 hours. This 1, 2, 3 hour is after the dextrose. So if the fasting is more than 95, that is abnormal. If 1 hour sample is more than 180, 2 hours, more than 155, and 3 hours more than 140. If any of the two values abnormal, then you will label the patient as diabetic, gestational diabetic. Please remember. So this is the Carpenter and Causter classification. Carpenter and Causter classification. So this is a two-step method. I think this is you understand. Now we'll come to the one-step method. And this two-step method is given by the ACOG, not followed in India because it is very cumbersome and you cannot. Now, one-step method. Please remember these all are method for gestational diabetes. For over diabetes, I have already told you. Now, one-step method, there are two methods. One is the WHO method, in which we take three samples. What we give? We give 70 grams of glucose. There is 8 hour of fasting. 8 hour of fasting. And first we'll also take the fasting sample. So fasting sugar, then 1 hour, and then 2 hours. If fasting is more than 92, 1 hour more than 180, and 2 hour 153. If any of the three is positive, then we will say that patient has gestational diabetes mellitus. Now, please remember, in case of ECOG two-step procedure, the second part, that is glucose tolerance test, just try to correlate. You say that out of the four reading were taken, and out of the four there were two reading has to be taken, whereas in WHO you have to give just 70 gram. In glucose tolerance test you have to give 100 gram. So this is more feasible, and only one of the reading is utilized there. Out of four, two has to be positive. Okay, so WHO, this was the WHO. Now there is also DIPSI guideline. DIPSI, DIPSI. What is DIPSI? Diabetes in Pregnancy Society of India. This is followed by Government of India. This is followed by Government of India. What does DIPSI says? It is also just like WHO. It is just like WHO. It is also a one-step procedure. In this, we also give 75 gram of glucose. 75 gram of glucose. But please remember, no fasting is required. No fasting is required. This is very important. Okay. And now you will do the sugar. Sugar is done after 2 hours. After 2 hours. Okay. If it is less than, it can be less than 120, 120 to 140. It can be more than 140 and it can be more than 180. How to remember? Please remember negro and remove R for remove. Now, and less than 120 is normal. I is for intolerance. That is, this 120 to 140 is glucose intolerance. That is glucose intolerance. That is glucose intolerance. And more than 140, then G. This is gestational diabetes. It is gestational diabetes. And O is more than, sorry, it is more than 200. It is overt diabetes. It is overt diabetes. Okay, so this is just remember from the neuro. So this is DIPSI. This is followed in Government of India and most of the areas. So this is related to the diagnosis. So we have gone to the pathogenesis diagnosis. We have undergone to the pathogenesis diagnosis. Now we'll see the complications. What are the complications that are present in the mm, diabetes? See, I have told you that in over diabetes there are two: congenital malformation and abortion. These are the specific complication which is present in the over diabetes, and they are not found in the gestational diabetes. So, if we talk of congenital, there are a lot of MCQs which are asked. Please remember, CVS malformation is more than the CNS malformation. CVS malformation is more than the CNS. And which CVS? Please remember, it is VSD. VSD. VSD is more common than the CNS, that is neural tube defect. Neural tube defect. So, if they ask you which is the most common, it is involved, congenital malformation is involved, system, it is CVS. In CVS, which is most commonly involved? Answer is VSD. Now there are 3 points which you have to remember. The first point, which is the most common overall congenital malformation? VSD. Most common CVS malformation? VSD. Okay, if they ask which is the most specific malformation, then answer will be caudal regression syndrome or sacral agenesis. But if they ask you which is the most specific CVS malformation, then your answer will be transposition of the great arteries. This is the understand. Understand. Okay, so if they ask you most specific, if they ask you most specific overall, then that is CRS, that is caudal regression syndrome, also known as sacral agenesis. But if they say which is the most, if they say most, shit, if they say most specific, if they say most specific, uh, most specific in CVS, especially they mention CVS, then there is transposition of great arteries. Transposition of great artery. Okay, so most specific overall, it is CRS, that is caudal regression syndrome. Most specific CVS. But if we ask you most specific finding in CVS, again please remember that is called as hypertrophic cardiomyopathy, because hypertrophic cardiomyopathy is not a congenital disease. Why it is? Because I've told you insulin acts like a growth factor. Please understand, insulin acts like a growth factor. So according to Penderson hypothesis, so what it is causes growth of the interventricular septum. So we get hypertrophic cardiomyopathy. It is not hypertrophic obstructive cardiomyopathy. So in the babies of diabetic mother, a lot of baby you will find slightly hypertrophic interventricular septum, but that will not produce symptom. So that is the most common finding. So again, most specific overall, it is caudal regression syndrome, but it is very rare. Please remember this. But it is very specific. And but if they ask most specific in CVS, that is transposition of great arteries, and overall it is the VSD. Now, so what all it can form in CNS? You can have neural tube defect. You can have meningomyelocele, that is meningomyelocele. You can have anencephaly. Okay, and in CVS, what can be seen? You can see VSD, ASD, transposition of great arteries, then hypoplastic left ventricle. In kidney, what can you see? You can see three things. Please remember them. It can be renal agenesis. Renal agenesis. Second, cyst. And third, duplex ureter. And so these are all the things. And in GIT, it can cause atresia of anal atresia. It can cause rectal atresia, and it can cause esophageal atresia. So these all are the malformation things, MCQs, which can be asked in the diabetes with now. Now, these are the complications. Now, there can be complications which can be common to both over diabetes and gestational diabetes. First, coming to the fetus. I have told you that in fetus there will be more insulin. Now you will understand why I was giving so much emphasis on the pathogenesis. So fetus there was most insulin, but when the fetus comes outside the mother, there is no glucose, but there is more insulin. So there will be fetal hypoglycemia. So infant of a diabetic mother, there is hypoglycemia. One should always be ready for hypoglycemia. Second, it can develop polycythemia. He or she can develop polycythemia. Now, why he or she develops polycythemia? Please remember, now go back to the pathogenesis. In pathogenesis, what was there? The spiral arteries were not able to dilate. They were not able to provide blood. So there will be ischemia. There was ischemia. So there was increased erythropoietin production in the fetus. And because of that increased erythropoietin production, there is polycythemia. So remember this thing. Third, there is hypertrophied cardiomyopathy. Why there is I have told you there was increased insulin in the fetus, and increased insulin was causing what? Increased growth of the fetus, of the tissues, bone, because according to the Penderson hypothesis. So there was slight hypertrophy of the interventricular septum. So that is why we get hypertrophy. This is the most common finding in the CVS. If they ask you most common congenital finding overall or in the CVS, VSD. But if they ask most common finding in CVS, then it is hypertrophic cardiomyopathy. Okay. Then it can cause respiratory distress syndrome. Why? Because I have told you the insulin prevents surfactant production, inhibits surfactant production. That's why. Fifth, hyperbilirubinemia. Hyperbilirubinemia. Why there is hyperbilirubinemia? Why there is hyperbilirubinemia? Now, there is polycythemia. So there is more RBC destruction. There is more RBC destruction. So there is hyperbilirubinemia, and that is unconjugated. Unconjugated. Okay. Sixth, you will see electrolyte imbalance. Hypokalemia, hypomagnesia, and hypocalcemia. Why hypokalemia? Because we have increased insulin in the baby. And when there is increased insulin in the baby, what will happen? It will push the potassium inside the cell. So these are the complications. And if you can remember them very well when you know the pathogenesis. When you know the pathogenesis, you can very easily. So these are the complication in the fetus. Complication in the, sorry, fetus, in the neonate. In the neonate, these are the complications. Now we will try to find the complication in the fetus. What will be the complication in fetus? Please remember, the fetus is, in fetus there is macrosomia. There is macrosomia. Why there is macrosomia? Because I have told you this, because of Penderson hypothesis, there is increased insulin. So insulin causes fat deposition, and especially fat deposition in the shoulders and the flank and the abdomen area. So there is macrosomia. Second, insulin also causes also, and there is macrosomia, and there is polyhydramnios. Polyhydramnios, why? Because there is increase glucose will lead to what? Act as an osmotic agent, so there will be increased urine. Please remember, can IUGR and oligohydramnios be present in fetus? Yes, it can be present. Generally, there will be macrosomia and polyhydramnios, but IUGR and oligohydramnios will be present only if there is a associated vasculopathy. This question has been asked. This question has been asked. Okay. So, vasculopathy, macrosomia. Generally, macrosomia and polyhydramnios will be present, but IUGR and oligohydramnios will be present in diabetes fetus if there is a associated vasculopathy or associated preeclampsia. Associated preeclampsia. This is very important. Now, what are the other fetus complication? Now, fetus can cause preterm premature rupture of membrane, cause preterm delivery, and it can cause intrauterine death. Why intrauterine death? We know that if this is the placenta, please remember we know that we have understand these are the villi like this, which has syncytial trophoblast and trophoblast. If there will be more glucose, so what will glucose do? Glucose will absorb water. So there will be increased edema in this layer. So there will be not proper oxygen and nutrient exchange. Oxygen and nutrient exchange will not be proper. So what happen? There can be an intrauterine death. So this is the reason if they ask you what is the cause of intrauterine death, it is because of excessive edema in the chorionic villi and excessive edema in the umbilical cord. The umbilical cord can have hydropic changes because of water accumulation. Hydropic changes. Because and why this water? Because of the sugar. So we have increased sugar in the chorionic villi leading to the chorionic villi edema. So oxygen and nutrients are not properly exchanged. Secondly, there can be hydropic changes in the umbilical cord. All these lesions can lead to intrauterine death. Please remember. So this is the complication in the fetus. What are the complications in the mother? Please remember. Now, if I ask you in mother, diabetes is a risk factor for hypertension generally, but hypertension is not a risk factor for diabetes. So simply this is a diabetes, so it is a risk factor for preeclampsia. For preeclampsia. So mother can develop preeclampsia. Mother has high chances of development of infection. Third, very important, mother can undergo shoulder dystocia. Can undergo shoulder dystocia. Can undergo shoulder dystocia. Okay. Why shoulder and PPH? Why PPH? Because the baby will be large, so there will be more stretch of the uterus, so it can go into the PPH after vaginal or cesarean section. And shoulder dystocia. Why shoulder dystocia? Because baby will be large. I will tell you. I will explain shoulder dystocia in detail because a lot of questions has been asked previously from shoulder dystocia. So this is उसको क्या है दो मना कर दो. Now we will see the treatment part. Now we'll see the treatment part. Now we'll see the treatment part. See, we know that there are two kind. One is overt and one second is gestational diabetes. Gestational diabetes. In gestational diabetes, you will initially do what? Lifestyle modification. That is energy, daily energy, daily calorie intake, daily calorie intake. Although it is a work of dietitian, but you should know. Please remember, daily calorie intake depends on BMI. It depends upon the BMI. Very important point. Now, if BMI is more than 30, this is the BMI. If BMI is more than 30, then calorie used should be 1250 to 500 kilocalories per day. Okay. If BMI is between 25 to 30, then calories should be 2500 kilocalories per day. If BMI is less than 25, then the calorie is 3000 kilocalories per day. Very important. Now, and also follow the rule of 40, 20, 40. That is 40 and 40 should come from carbs and fats, and 40 and 20 should come from the protein. So this is the calorie. How much calorie should, plus there should be mild to moderate exercise for 15 to 30 minutes. So these are the lifestyle modification. Then you will assess the patient after 2 weeks. And what is the goal? Goal that HbA1c should be less than 6%, or fasting blood sugar should be less than 95, 1 hour should be less than 140, and 2 hours should be less than 120. If these things are done, then you will continue to manage the patient like this. And you will continue to manage the patient like this. But if these four things are not being, we are not able to get these four things, or if the patient is of over diabetes, then we will directly go to the pharmacological management. Directly go to the pharmacological management. So if I ask you what are the indications of pharmacological management, so indication for pharmacological management is when the is first over diabetes mellitus. Second, if after 2 weeks of lifestyle modification we are not able to get these four things, okay, then you will go for the. And what is the drug of choice in gestational diabetes or over diabetes? Answer is insulin, insulin and insulin. If by chance lady is not able to take insulin, or she said that she said that I cannot take injections, I want oral, then you can give other two drug, that is metformin and glyburide. No other oral hypoglycemic drugs is suitable for indicated for diabetes. So what is the drug of choice? Insulin. Oral hypoglycemic drug should not be used, but if there is a compulsion to use oral hypoglycemic drug, then only two drugs can be used. First is metformin, second is glyburide. Okay, these are the two drugs. So this was regarding the treatment part which can be asked to you. Now, what is the best timing to what is the best timing? What is the best timing for delivery? So please remember, you have to divide. First is over diabetes mellitus. Second is gestational diabetes mellitus. Now you have two kind of gestational diabetes mellitus. One were on insulin, and second who were managed by diet and lifestyle modification. Lifestyle diet and lifestyle modification. Diet and lifestyle modification. So over diabetes mellitus, the best time is 37 week to 37 week 6 days. Okay, if she is managed by diet uh, and if the gestational diabetes on insulin, then best time is 39 week to 39 week plus 6 days. Okay, if the lady is being managed on diet and lifestyle modification, then best time is from 39 week to 40 week 6 days. Okay, so please remember this, because a lot of question, you they can give you that this is the diabetes, then how, when is the best time to deliver? Okay, now we have to understand shoulder dystocia. As we have seen that the lady can develop shoulder dystocia. What is shoulder dystocia? That during normal vaginal delivery, during NVD, normal vaginal delivery, the baby head came out, but shoulder is not deliver. That is called as shoulder dystocia. So it is a complication of shoulder dystocia. Shoulder dystocia. Dystocia is a complication generally seen in cases of the diabetes mother. What happened? Now I've told you that there is macrosomia in fetus in diabetes. When to call macrosomia? If it is more than 4 kg. If it is more than 4 kg, we call it macrosomia. If it is more than 4 kg. And please remember, macrosomia is not an indication for cesarean section. This question has been asked. If what is the indication for cesarean section? If the weight is more than 4.5 kg in diabetic mother, and if the weight is more than 5 kg in case of non-diabetic mother. This is, please remember these point. This is the indication for cesarean section. More than 4 kg is not. More than 4.5 if it is the mother is diabetic, more than 5 kg if there is non-diabetic. Now shoulder dystocia, what is the first thing that you will do? The first thing that you will do is Mac Robert. So I will tell you, write Madhya Pradesh in India. Okay, so just invert M and write down it like W, and P is like R. So please remember this, MPIRW. First thing is Mac Roberts maneuver. Then is posterior arm delivery. If this doesn't work, then if it doesn't work, then there are certain maneuver involving the internal rotation, like wood cork screw maneuver. And other maneuver that you can use is, please remember, which are not used, is Gaskin maneuver, Rubin maneuver. So write MP in India, and just write M is like, W is like inversion of M, R is like P. So I need remember this. Okay. So what is Mac Roberts maneuver? So this is Mac Roberts maneuver. What is Mac Roberts maneuver? This is Mac Roberts maneuver. What? So in Mac Roberts, this is Mac Roberts maneuver. Mac Roberts maneuver. Total of 3 plus 1. 4 people, one obstetrician who will take the baby out, and 3 other people, nurse or this OT staff. So one person will stand like this and put, one person will stand on the one side, and other person will be, this person is standing on that side, and another person will be standing on this side, which is not showing in the diagram. And this person will completely flex the thighs, and also abduct the thighs. So there is hyperflexion and hyperabduction of the thighs, and similar will be done by the other person. And what another person will do? Another person will apply a suprapubic pressure. Suprapubic pressure. Suprapubic pressure. Please remember, in MCQ they can say fundal pressure. Fundal pressure is not given. Fundal pressure is not given. Fundal pressure is not given. So now, please remember what we'll do. Call for help. Call for help. And what we will not do. Fundal pressure. Fundal pressure is not done. And pulling from down. Pulling from down. Don't try to pull the baby. These things are not done. And then you will follow the Mac Roberts maneuver, where 4 people will be there. Two of them will try to hyperflex the thighs and hyperabduct the thigh, and one will give the suprapubic pressure. Suprapubic pressure is allowed, but not fundal pressure. Okay, so this is what is called as the Mac Roberts maneuver. If this maneuver doesn't able to make the baby out, then you will do what? You will take your 3 fingers, you will try, you can also give episiotomy. Please remember, episiotomy. You will give episiotomy, and you will put your 3 finger inside and try to deliver the posterior arm, because if posterior arm will come out, now the space will be increased. Now you have to just deliver the shoulder, remaining shoulder and arm. So then you will do the posterior arm delivery. If that also fails, then you will go for the internal rotation maneuver, that is Woodcock screw maneuver. Okay, so this is what you have to understand. So this is what is called as woodcock's screw maneuver. Okay, this is a kind of internal rotation maneuver. You have to rotate the baby not from the uh, head or the neck, by the shoulder. By you have to grasp the shoulder and rotate. You have to generally give episiotomy, put your hand inside, and you have to rotate the baby generally in this direction. Okay, so this is, if they show you, this is what, this is the Wood's cork screw maneuver. It involves internal rotation. Okay, what is this? This is gasket maneuver. This is not used. The lady is on his two hands and knees and then try to take the baby out. This is not used. Similarly, Rubin maneuver also not used. And this is what, this is the posterior arm of the baby, and the obstetrician is trying to deliver the posterior arm. So this is posterior arm delivery. Posterior arm delivery. So you have to understand, first is the McRoberts maneuver, then posterior arm delivery. If that doesn't work, internal rotation maneuvers like Wood's cork screw maneuvers. And then there are two maneuvers which are not used, Gaskin and Rubin. Can anybody tell me where other we have studied Rubin in gynecology? Yes, we have studied Rubin criteria to diagnose cervical ectopic pregnancy. Okay. Now, if all these doesn't work, then you have to go for the surgery. Which surgery? You have to break the clavicle of the fetus, that is cleidotomy. Cleidotomy. Or you have to break the symphysis pubis of the pregnant lady, that is called as symphysiotomy. Symphysiotomy. And then there is a maneuver that is called as ZAVANE maneuver. Javanelli maneuver. What is this maneuver? This is the last maneuver. What happened in this? In this, you will push the baby inside and you will do the cesarean section and takes the baby. How to remember in Hindi? Remember Java Nali. Nali, am not saying that it is Nali, but just to remember that you ask the baby to Java Nali. Jao Nali mein. So Java Nelly maneuver. Zavanelli. This is the last resort. In this, you push the baby back into the birth canal in the uterus. You do the cesarean section and take the baby out. So this was regarding shoulder dystocia. If you know this, you can do everything. So now we have finished with the diabetes. Now we'll come to the third part, that is thyroid disease in pregnancy. So just be with me, although no one is with me, and we'll finish thyroid disease in pregnancy within 15 minutes. Okay, so first we have to understand the normal. There are thyroid releasing hormone, there is thyroid stimulating hormone, then we have T3, T4, and we have to beta HCG. Okay, so we know if in pregnancy beta HCG starts secreting at 8th day. So 8th day it starts secreting, 8th day, and it becomes maximum at 8 to 12 week. At 8 to 12 week it becomes maximum and then it plateaus. Now beta HCG I have told you is like LH, FSH and TSH. So when beta HCG act, if for example if this is the thyroid hormone, if this is the thyroid gland. So in thyroid gland what happens? There is hyperplasia and slightly hypertrophy. Please remember, but if there is any goiter, if any palpable or if any visual swelling is there, it should be, it is not a physiological change. It is not a physiological change. Any growth is, it has to be evaluated. Okay. There is slight hyperplasia and hypertrophy, but there is no goiter. Okay. There is no visible or palpable growth. If there is a visible or palpable growth, that is abnormal. So thyroid gland, so it will secrete more T3, T3 and T4 increase. Just be with me. Now T3 and T4 are in the unbound form. Second, it is bound with the thyroxine binding globulin, which is secreted by liver. Come, just see what is thyroxine binding globulin. Thyroxine binding globulin, it increases like this. Thyroxine binding globulin, thyroxine binding globulin. It increases and it becomes maximum at 20th week. It becomes maximum at 20th week, and then it becomes a does a constant. So this thyroxine binding globulin binds with the T3 and T4. What is T3 and what is T4? T3 is triiodothyronine. Thyro, thyronin. This is the active form, and this is the thyroxine. T4 is converted into T3 for action. This you all know, I think. You must have read in the philosophy. Now, though thyroid gland, there is hypertrophy and hyperplasia, so there is increased T3, increased T4. But you see, there is also increased thyroid binding globulin. So what happened? As the unbound T3 increases, it gets bound with the thyroid binding globulin. So bounded forms increases, whereas unbounded form remains constant. Remains constant. So what happened to the total T3 T4? Total T3 T4 increases because bounded form increases. So unbounded form is constant. Bounded increases because of increased binding with the thyroxine binding globulin, and total T3 T4 increases. Okay, now since now beta SCG act like a TSS, so it uh, gives a positive feedback to the thyroid gland and increases T3 T4. Okay, so TSH value remains within normal limit in pregnancy. Now if I so there are a lot of question can be framed from this. What there can be? TRH and TSH, no change in pregnancy. No change in pregnancy. That means their value, uh, they are within maximum and minimum values, normal maximum and minimum value. Unbound T3 and T4 constant. Bounded T3 and T4 increases. Total T3 T4 increases. TBG increases. So you have to remember all this thing and can be good. Beta SCG, you all know, like, remember this graph. So these all can be asked as a question. Okay, this TSH cannot cross the, please remember, TSH cannot cross the placenta. There are 5 hormones which you have to remember cannot cross the placenta, which are insulin, thyroid stimulating hormone, erythropoietin, calcitonin, and parathormone. These are the 5 hormones which cannot cross the placenta. You have to remember them. So this happens. So now please remember, if we for your NEET PG, TSH is unchanged, but actually there is a slight during this time when 8 to 12th week, when beta SCG is maximum, there is a slight dip of TSH, but this dip is very small and it is within its normal limit. Therefore, we say that TSH is normal. So if someone asks you TSH remains within normal limit, yes, TSH is unaltered. But yes, at a macro level, micro level, there is a slight decrease in TSH. Okay, so this is this was the pathogenesis, and most of the thyroid disease in pregnancy are auto antibodies. We know that thyroid stimulate thyroid. Most common cause of hyperthyroidism is the grave disease. This has been asked. Most common cause of hyperthyroidism is a grave disease. Then there is a very important antibody, that is TPO antibody. This is thyroid peroxidase enzyme. Thyroid, thy, thyroid, thyroid peroxidase enzyme. Peroxidase enzyme. What does it do? It converts the iodine minus to iodine. This. And this, if the antibodies are formed against this, that is called as Hashimoto's thyroiditis. Hashimoto's thyroiditis. This has been already explained to you in surgery, but please remember that in TPO antibodies, anti-TPO antibodies, this antibody earlier was called as thyroid microsomal antibody. They were called as thyroid microsomal antibody, but now it is called as TPO antibody seen in Hashimoto's thyroiditis. Okay, so this is what. Now there can be, now one of the question that is asked a lot, that in hypothyroidism, what can be the effect on hypothyroidism? What can be the effect on the fetus? So there are a lot of mnemonic, but just try to, I'm telling you a trick, that when there will be thyroid, there low thyroid, what will happen? The baby will not able to produce blood, so there will be anemia. So there will be anemia. And whenever there is anemia, the baby will not, it is just a story, it is not a concept. And whenever there will be anemia, baby will not able to grow. Neither the baby mind will able to grow. So there will be intrauterine growth retardation and there will be mental retardation. There will be mental retardation. This is just a story. And when baby will not able to grow, he will try to come out. So there will be preterm labor. There can be preterm labor or preterm delivery or preterm premature rupture of membrane. But if you will try to take the baby, you will not, if you will compel the baby to remain inside, it will cause some mischievous things. That is, it will cause preeclampsia, or even the baby can do suicide or miscarriage. So please remember this. Okay, this is the that anemia, IUGR, mental retardation, preterm labor, preterm delivery, PPROM, preeclampsia, and microcarriage. Now, very important point. Now I'm going to tell you. When we were studying, mm, when we were studying what? When we were studying diabetes, where we see that the baby can have polycythemia. So please remember, in hypothyroidism, we have anemia and mental retardation. These are not a feature of diabetes. These were not a feature of diabetes. This has been asked. Anemia and mental retardation are not a feature in case of diabetes. There we have seen even polycythemia. So this is what you have to understand. Now, if we see hyperthyroidism, what is the treatment in hypothyroidism? We'll give T4, that is, and the levo form, that is levothyroxine. Now you can ask me that why we don't give T3. Please remember, we don't give T3 because half-life of T3 is 1 day. And according to Davidson medicine book, it is 18 hours. So if you will give, it will be cleared. So a constant, and we give, so it will not be present constantly at a level and it will be cleared off. Second point is that if it is, and it can also cause toxicity if high dose is given because it is the active form. For example, if you are giving T4 and instead of 50 microgram you have given 75, so that cannot cause toxicity because this T4 has to get converted into T3. But if T3 will be given at a increased dose, that can cause toxicity because it is itself is the active form. So this is the one reason why we don't give T3, and the second reason we don't give T3 because it has a very half-life, very less half-life, whereas the half-life of T4 is 7 days. So therefore we give thyroxine, that is levothyroxine T4. So this is very important point. Now coming to the hyperthyroidism, what can hyperthyroidism cause? More IUGR. So please remember, IUGR can be seen in hypothyroidism as well as the hyperthyroidism. Plus hyperthyroidism can also cause preeclampsia. preeclampsia. It can cause heart failure, miscarriage. All these things can be seen in cases of hyperthyroidism. Okay, miscarriages, heart failure. Now coming to the treatment of hyperthyroidism. Now in hyperthyroidism, you can have medical treatment, and second you have surgery. Please understand, surgery is done in only two cases. First, if the patient is not responding to medical management, or second, the patient has some respiratory problem because the thyroid swelling is compressing the respiratory trachea, that is stridor or respiratory depression. So surgery is done only in two cases: if the patient is not responding to medical management, or there is some problem in the respiratory depression or stridor is present. Otherwise surgery is not done. And what is the best time to do the surgery? So best time is second, that is between 12 to 28 weeks. Second trimester. Best is second trimester. Always remember, second trimester is the best time. Surgery is avoided because there is hypervascularity of the thyroid gland. So there can be increased chances of the bleeding. So surgery is only done if there is no medical management, not responding to medical management, or there is respiratory depression or stridor. Now what is the medical management? Medical management, always remember PM rule. PM rule. P is for propyl thiouracil, and M is for methimazole, mazole or carbimazole. This is given till first trimester, and from second trimester, methimazole or carbimazole is given. Why propyl thiouracil, methimazole and carbimazole is not given in the first trimester? Please remember, earlier what was there, that this propyl thiouracil was given till second trimester. But in 2009, FDA has given a black box warning about propyl thiouracil, that is causes hepatotoxicity. Hepatotoxicity. Severe hepatotoxicity. Therefore, it should be just given for the first trimester. Now, methimazole and carbimazole side effect is aplasia cutis of neonate, conal atresia, esophageal atresia. Okay. So these, it can lead to these things. Therefore, it is not given in the first trimester. It is given from the second trimester. Okay. So first trimester, it is propyl thiouracil. What is the side effect of propyl thiouracil? One is, you know, that it is causes hepatotoxicity. Therefore, it is just given for first trimester, and then switch over to, once organs are formed, we switch over to the methimazole or carbimazole. Side effect is it causes neonatal hypothyroidism. Neonatal hypothyroidism. It can cause neonatal hypothyroidism. Second, it can cause agranulocytosis. Agranulocytosis. Agranul agranulocytosis and leukopenia, and also known hepatotoxicity. So remember this PM rule. So this is, I think, thyroid disease. This was regarding the thyroid disease. Now coming to the cardiac disease in pregnancy. Just give me just 2 minutes, then we will. This is a very important thing. Cardiac disease in pregnancy. चक्कर आने लगा था। कौन है? Now we have to understand what are the how to identify a cardiac disease. For example, normal if a not what will see in a normal pregnancy, and second, what is pathological. We have to know these things. Now S1 is loud in normal pregnancy and split can be present. S2 is present, S3 is present, but S4 is not present. So presence of S4 is pathological. Then there is persistent split of S2 is pathological. Okay. Systolic murmur till grade 2 is physiological. Till grade 2 is physiological. These all things are asked in MCQ, so you have to remember systolic murmur of grade 3 and D for death, D for die. So diastolic murmurs are always pathological. Now coming to the ECG normal finding, you can see left axis deviation, large Q waves in lead 3, increase QTC. Regarding QTC and this Q wave, I have explained in great detail in my first lecture. So these are normal. Okay. What will be abnormal? Any left bundle branch block. And then RBBB can be normal. This you have to understand. What are the other things that is pathological? If raised JVP, raised pulmonary capillary wedge pressure, JVP is normal. Okay. So these are the pathological things. Presence of any cyanosis, presence of hemoptysis. Okay. If there is presence of PND, paroxysmal nocturnal dyspnea, the patient will complain that during nights I feel suffocating and I get up that and I feel that someone is trying to squeeze my neck. That is called as paroxysmal nocturnal dyspnea. Okay, so these are abnormal things. Uh, arrhythmia, arrhythmia, except which two arrhythmia? Sinus tachycardia, and sinus arrhythmia. What is sinus arrhythmia? Normally during inspiration, when you take inspiration, BP fall and heart rate increases. So in inspiration you have tachycardia and expiration you have bradycardia. So there is normal this so there is change of heart rate during inspiration and expiration. This is called as sinus arrhythmia, and this change is not more than 10. If so, this is called as sinus arrhythmia. So this arrhythmia, these two arrhythmias are called. If any arrhythmia other than this is abnormal. Okay. So this you have to understand what are the pathological things. So by this you can easily diagnose that is this lady is having cardiac problem or not a cardiac problem. Now different lesion toleration. Now we can have cyanotic and acyanotic lesion. We can have MVP. Now if they ask you question which is the most tolerated lesion, the answer is the most tolerated lesion in pregnancy. Most tolerated lesion in pregnancy. If they ask you most tolerated lesion in pregnancy, your answer will be MVP, that is mitral valve prolapse. And if they ask you least tolerated, then your answer will be Eisenmenger syndrome. Eisenmenger syndrome. Eisenmenger syndrome. This is the least tolerated. Now, I'm telling you, understand this diagram. This is your heart. This is your left atrium, this is your right atrium, this is your left ventricle, and this is your right ventricle. Okay, and this is aorta coming out from the left ventricle. Now, left to right shunt means, for example, if we take VSD, uh, this will go like this, and this is the pulmonary artery. Pulmonary artery. The blood will go from, so this will be the oxygenated blood, this will be the deoxygenated blood. So, oxygenated blood will go to the here. And what happened in pregnancy? In pregnancy, because of the progesterone, peripheral vascular resistance decreases. So there is decreased pressure in the aorta. So whenever there is decreased pressure in the aorta, normally left side pressure are more. So there is left to right shunt. So what happened? There is decreased pressure in the aorta. So left, so that will be transmitted to the left ventricle. So what will happen? The left to right shunt will decrease. Why left to right shunt will decrease? Because now there is because of the progesterone there is decreased peripheral vascular resistance, so there is decreased pressure in the aorta, and decreased pressure in the aorta is transmitted to the left ventricle. So now this left side pressure will decrease, so there will be left right to left shunt. So left to right shunt are well tolerated in pregnancy, please remember. Now just in the same diagram, now if I draw a diagram like this, see this, everything is just like same. In right to left shunt, what will happen? There will be decrease. This is aorta, so there will be decreased pressure here, decreased pressure here. So what will happen? Right to left shunt will increase because now the pressure on the right side will increase than the left side. So there's that's why right to left shunt are not well tolerated. Right to left shunt are not well tolerated because the left ventricular left side pressure is decreases. Therefore, that's why the cyanotic, that is right to left shunt, are not well tolerated, not well tolerated. The reason I have told you. And acyanotic, that is left to right shunt, left to right shunt, these are well tolerated, these are well tolerated. Okay, now again coming to the, we have stenotic lesion and we have regurgitation lesion. Please remember S for stenotic, S for SAD in pregnancy. So stenotic lesion are not well tolerated, not well tolerated in pregnancy, whereas regurgitation lesion are well tolerated. That's why even severe aortic regurgitation, severe mitral regurgitation, they can very easily. Why? Now you see the there is dilated, there is peripheral vascular resistance decrease, there is vasodilatation, so aorta pressure is less, diastolic pressure is less, so there is no regurgitation. Regurgitation occurs because of the diastolic pressure. That's why regurgitation is less, and so regurgitation lesion even they becomes better in the pregnancy. Okay, whereas the stenotic lesion they worsen in the pregnancy. So this is uh, and if I ask you in aortic stenosis and mitral stenosis, which is worse? Aortic stenosis is much more worse. Okay, so stenotic aortic stenosis, then mitral stenosis, and then regurgitation lesion. This is the order of toleration. So I have explained you the reason. Now, in PG में commonly they ask you which heart problem is worst tolerated. maximum mortality, or you will advise MTP, or pregnancy is contraindicated. So answer to all these is Eisenmenger syndrome. Eisenmenger syndrome. If a lady has Eisenmenger syndrome, you will not advise pregnancy. Pregnancy is contraindicated. If pregnancy is there, you can give MTP, then you can give MTP. If you will not give MTP, lady has already crossed that limit, then there is very high chances of mortality because it is worse tolerated. So answer to all this question is this. Now, if Eisenmenger syndrome is not in the option, then what are the other um, cardiac condition which are worse tolerated, or you will advise MTP, or pregnancy is contraindicated? So there is a list. First is, if there is Marfan syndrome with aortic root involvement. Aortic root involvement, how much? 440 millimeter. That is around 4 centimeter involvement. Second, coarctation of aorta with aortic root involvement like this. Third is severe aortic stenosis, severe mitral stenosis, severe symptomatic aortic stenosis, and NYHA grade 3, 4, ejection fraction less than 30%. Okay, so all these condition, heart, the heart problems, pregnant, these heart problems are worst tolerated, have maximum mortality, MTP advised. If in option Eisenmenger syndrome is given, they can ask you like this, that they will ask, then Eisenmenger will be the option. But if Eisenmenger is not in the option, any of them can be picked. Okay. And so these are all the indication of pregnancy contraindication, all are indication of MTP, where MTP is advised, or maximum mortality, and was tolerated. So you have to remember these things. And yes, one I was forgetting, that is peripartum cardiomyopathy. Peripartum cardiomyopathy, very disastrous condition. Cardiomyopathy. Okay. So you have to remember this table. So if they ask you any of this is given in there in the question, you have to answer these things. Now, peripartum cardiomyopathy. If I ask you what is the time that peripartum cardiomyopathy present, it can present if this is the delivery. It is delivery time. It can produce 1 month before delivery and can produce till 5 months after delivery, can produce after till 5 months after delivery. So remember this timing, peripartum cardiomyopathy. Now, peripartum cardiomyopathy, how to diagnose? On echo, what are the findings? You will see this is the left ventricle which is totally dilated. This is totally dilated. So what you will see? You will see global hypokinesia of left ventricle. First thing that you will see. Second, you know that there is something called as left ventricular end diastolic volume. That is the volume of the ventricle after complete diastole. The normal value is 36 to 52 millimeter, 3.6 to 5.2 centimeter. So a value more than 52 millimeter or 5.2 centimeter is diagnostic of peripartum cardiomyopathy. Then moderate to severe MR or TR. Why? Because there will be more blood, so that can come upside. And fourth, ejection fraction less than 45%. And fifth and very important point, please remember, no other cause of heart failure. No other cause of heart failure. For example, if there is mitral stenosis, then you cannot make a diagnosis of peripartum cardiomyopathy. Okay, so no other cause of heart failure. No other obvious cause. No other obvious cause of heart failure is seen. Now what are the markers? One marker that is in front of you is anti-pro-BNP. Now there are BNP and anti-pro-BNP. Why anti-pro-BNP is generally preferred over BNP? The reason behind this is that the anti-pro-BNP has a half-life of 120 minutes. Has a half-life of 120 minutes. So it can, so it's, whereas BNP has a very short half-life. So it's better to, it is always better to measure anti-pro-BNP. Second, the increase in anti-pro-BNP is very large in heart failure, whereas in BNP the increase is not very hard. So it becomes very difficult to make a set point. So that's why. And third is, these are the two main reasons. Because of the increased half-life, anti-pro-BNP is measured, and second, the increase in anti-pro-BNP in acute heart failure is very large. Okay, so set point can be made. So what is the normal anti-pro-BNP value? Please remember, when to say that there is acute heart failure. Acute heart failure. This value of anti-pro-BNP will be used in the peripartum cardiomyopathy, and this same value can be used in other heart failure, in the normal heart failure. What is, till 45 years, value should be less than 450 picogram per ml. From 45 to 70 years, value should be less than 900, and above 70 year, value should be less than 1800. So when you will say that heart failure occurs in 45 years, when the value is more than 450 picogram per ml, in case of 45 to 70 years, more than 900 picogram per ml, and in 70 to 80 years, if there is uh, more than 1800 picogram ml. A value less than 300 is very unlikely that there is heart failure. Is very unlikely that there is heart failure. So this is the regarding the anti-pro-BNP and the BNP. So this is one of the marker. Other marker is C-reactive protein. C-reactive protein, and it can also be used in the prognosis. C-reactive protein can be used in the prognosis, but C-reactive protein cannot be used in the prognosis. But anti-pro-BNP can is best. If they ask you maximum sensitivity, that then answer will be anti-pro-BNP, maximum sensitivity. But if they ask you maximum which is used in prognosis, then CRP. And other marker are interferon gamma. Then other is FAS APO1. Although nobody does this, but you have to remember, if they want to make a good question, then they can make CRP, interferon gamma, FAS APO1. Then asymmetrical dimethyl arginine. Asymmetrical dimethyl arginine. So these are the, then there is also cathepsin. Sorry, if you can remember, please remember, these are the other marker, interferon. And yes, very important, 16 kd prolactin. Now this can be asked because a lot of research is being done on this. Now please remember, it has been seen that there is a molecule 16 kd prolactin which is involved in the pathogenesis of the peripartum cardiomyopathy. And it's so it is raised, it can be used as a marker. Now how the scientists reached to this, that 16 kd prolactin can be involved in the peripartum cardiomyopathy? Because now in the treatment of peripartum cardiomyopathy, bromocriptine was given, which is a D2 agonist, which is a D2 which is a D2 agonist. So it blocks the prolactin. So it blocks prolactin, and it has shown some good, it blocks prolactin, and it has shown some good response. So that's why they started research in the way of prolactin, and they found this, that 16 kd prolactin. You can search on the Google and can read about it if you have time. 16 kd prolactin is involved in the peripartum cardiomyopathy. That, and also remember, that's why prolactin is involved. If they ask you which hormone is involved in peripartum cardiomyopathy, it is prolactin, specifically 6 kd prolactin, and bromocriptine is used in the treatment of peripartum cardiomyopathy. Now, we have shown that anti-pro-BNP can also increase in other causes. For example, but I don't think here it is necessary to write them down. It can also increase in the chronic obstructive pulmonary disease. It can also increase in pulmonary embolism after cardiac surgery, after cardiac mm, after cardiac trauma. It can also cause in sepsis, in certain snake bite, in cases of the burns, in case of anemia, hypertension, hyperthyroidism, or there are, it's a long list. And so all these condition anti-proBNP can also rise. So in pulmonary artery hypertension, but you don't have to remember that. You have to remember this much only. Now, please remember, peripartum cardiomyopathy is a very dangerous condition, because there is, even if there is complete resolve, if the peripartum cardiomyopathy is completely resolved, risk of recurrence in is 20% if it is completely resolved. After complete resolve, if after it is completely resolved, and if the residual disease is present, then risk of recurrence is 45%. You have to remember this 20 and 45%, because both have been asked. Okay, if there is no residual, completely resolved, the risk of recurrence in the next pregnancy is 20%, and if there is a residual disease, then the risk of recurrence is 40%. This you have to understand. Okay, so this is a very important slide. A lot of question can come. Now, management of heart disease. Now, please remember, in stenotic lesion, you have to prevent tachycardia. I have told you that stenotic lesion is S for SAD in pregnancy, simply S, after S there is T, that is tachycardia. So you have to prevent tachycardia in stenotic lesion, because if there will be tachycardia and mitral stenosis or aortic stenosis, so what will happen, that the diastolic time will decrease, and the left ventricle end diastole volume will decrease, so ejection fraction will decrease. So this is better to be read in medicine. So we have to prevent tachycardia in stenotic lesion. You remember this, stenotic lesion, and bradycardia in regurgitation lesion. Okay, so this I have explained you. Now, when to admit? Please remember, this is according to, this can also be asked, if the NYHA grade 3 and 4, they are contraindication for pregnancy, but if they got pregnant, admit from the start. From the day lady get pregnant and it is diagnosed with pregnancy, and you know, NYHA 1, admit at 36 week. NYHA grade 2, admit at 28 week. So this you have to understand, that when to admit and when not to admit. Okay. So you have to prevent tachycardia in stenotic lesion, and you have to prevent bradycardia in the regurgitation lesion. Now, delivery in heart disease, what is the best method? So now I'll tell you 5-6 points which are generally asked. Best method is vaginal delivery. Please remember. Best method is vaginal delivery. Now, in the MCQ, they can give you these 5 points. Can you do induction of labor? Yes, induction of labor is not contraindicated. Yes, you can do induction. Can you do augmentation of labor? Augmentation of labor with oxytocin? Yes, you can do. This is very important. Cut short second stage of labor. See, yes, you can cut short second stage of labor, but it is not mandatory. So understand these points. Vaginal delivery is preferred. Induction of labor can be done. It is not a contraindication. Augmentation of labor can be done. Cut short of second stage can be done, but it is not a mandatory. Fifth, rupture of membrane. Yes, can be rupture of membrane can be done. So always remember these 5 points, because they can confuse you around this, that induction of labor, augmentation, cut short of, and rupture of membrane. These three things can be done. You have to remember this. Okay, so that's why I wanted you. So best method is vaginal delivery, and induction, augmentation of labor, and rupture of the membrane can be done. Indication of cesarean section. When you will do cesarean section, when GA has to be used. These all are asked a lot of time. Now, indication of cesarean section is, please remember, if there is aortic root involvement of 4 centimeter or more in Marfan syndrome, or coarctation of aorta, you will go for cesarean section. If there is aortic aneurysm, then if there is severe aortic stenosis. Earlier, severe mitral stenosis was also indication for cesarean section, but now, not now. In severe stenotic mitral stenosis, GA is done. Sorry, it can be. It's not an indication of cesarean section. Severe aortic stenosis. Then acute heart failure and recent MI. Okay. Now, I have told you which is more dangerous, AS or MS. I have told you AS, aortic stenosis, is more dangerous. Now, pregnancy with warfarin or heparin, which route will be preferred? Please remember, warfarin can cross the placenta. Although warfarin is best anticoagulant for prosthetic wall, but warfarin can cross the placenta, and warfarin can cause a lot of damage during organ formation. So please remember, I'm going to tell you one thing, that when pregnancy, this is also asked, pregnancy with anticoagulant, pregnancy with anticoagulation. Now, warfarin is very good, but it can cross the placenta. Therefore, in initial 0 to 12 weeks, what is used? Heparin is used. Heparin is used. Then 12 to 36 weeks, what is used? Then you can use warfarin, because it's very good. Then heparin is used. Then after 36 weeks, again we switched over to heparin, and then stop 12 hours before delivery, and restart कब करते हैं? When to restart? 6 hours after vaginal delivery and 24 hours after C-section. And this is according to William Obstetrics. Okay, so initial 0 to 12 week, what you will use? You will use heparin. Why you will use heparin? Because during organ formation is there, warfarin can destroy those organ formation. Then 12 to 36, you will again come to the warfarin, because warfarin uh, uh, is more good than heparin. Is much better than heparin. Okay, in cases of prophylaxis of patient having prosthetic valve. And after 36 weeks, you will again come on heparin and stop 12 hours before delivery and then restart. Now, why during after 36 weeks we again come to the heparin and not warfarin? Because please remember, The preferred mode is vaginal delivery. When you will do vaginal delivery, warfarin can cross the placenta. Warfarin can cross the placenta and can go to the baby, and there can be cerebral hemorrhages in the baby during vaginal delivery. Therefore, it is after 36 weeks we again come on the heparin. But if by chance baby is on the warfarin, we don't go for the vaginal delivery. Why? Because during the stress, during that vaginal delivery, that warfarin has crossed the can cross the placenta. It has crossed the placenta. It is present in the fetus, so it can cause what? It can cause cerebral hemorrhage. So if there so we try to prevent that. After 36 we used heparin, but if the pregnancy is with heparin, we are not able to stop somehow, then we'll go for the what? Caesarean section. Therefore pregnancy with warfarin is also an indication for caesarean section. But with heparin, yes, you can go for the vaginal route. Now also, this is the reason. Also, you don't have an antidote of warfarin. For heparin, you have an antidote, that is protamine sulfate. Protamine sulfate. Protamine sulfate is an antidote. That is the reason. So, pregnancy with Eisenmenger syndrome, which route is preferred? First of all, Eisenmenger syndrome, you don't advise pregnancy. If it has gone, please remember the mortality is very high. It is so high, around 90% with vaginal as well as cesarean section both. So why to waste things? We go for the vaginal delivery. This question has been asked that a lady of Eisenmenger syndrome has become pregnant. Now what is the mode of delivery? Answer will be vaginal delivery and the vaginal delivery. Okay. So this I think now anticoagulants. So this was regarding the management of the heart disease in pregnancy. I don't think anything is left. Let's see, is anyone on the uh, prevention aspect? Also remember one thing, IAS, that is anemia. If there is an anemia, that has to be corrected. If there is any hypertension, that has to be done. These are the normal things. Then there should be salt and water restriction. In preeclampsia, there is no need of salt and water restriction, but here it will help. So this was the third lecture, and thank you for watching. And in two more lecture, your option gynae will be completely finished. Thank you. I will upload the lecture very shortly. And thank you. Be with me. Okay.